standard. He is a school teacher by occupation. He is a resident of Shadra, New Delhi. Upper middle class society. Upper middle class society according to the modified Kupu-Swami scale, and he presented to the OPD yesterday with chief complaints of abdominal distension since 6 months, swelling of the legs since 15 days, breathlessness since 15 days, and yellowish discoloration of eyes since 7 days. History of presenting illness. The patient is a chronic alcoholic since past 25 years. Patient was apparently well 6 months ago when he noticed generalized abdominal distension, which was insidious in onset, gradually progressive, associated with sense of heaviness and discomfort generalized over the abdomen, no pain or fever, no constipation. 1 month before, the patient had to take leave from his work due to his deteriorated condition. Patient also visited a local practitioner and was prescribed some medication, which somewhat relieved his abdominal distension. The medication also led to an increase in his urine output as well. However, his condition again worsened on discontinuing the medication. No history of hospital stay. Patient did not undergo any medical procedure. Swelling in the legs was for 15 days. Insidious in onset. It was first noticed bilaterally on both the foot. It was gradually progressive upwards. Now it progressed till the knee. No history of facial swelling or puffiness. No history of calf pain, scrotal swelling, or no history of reduced frequency or amount of urine. Breathlessness was for 15 days. Breathlessness was of insidious in onset and gradual in progression. Initially, patient felt breathlessness after walking 500 meters on level ground. Now it has progressed to being breathless after walking 100 meters on the ground. Breathlessness increases on lying down. It is not associated with any cough, sputum. It is no history suggestive of paroxysmal nocturnal dyspnea, platypnea, or trypopnea. No history of chest pain or palpitation. Yellowish discoloration of eyes. Patient also complains of yellowish discoloration of eyes since the past 7 days, which is associated with dark colored urine. It is not associated with any fever. No history of clay colored stools. No history of generalized itching over the body. There is no history of blood in vomitus or dark tarry stools. No history of easy bruisability. No history of fever. No history of evening rise of temperature. No history of sleep disturbance, drowsiness, irritability, or altered sensorium. No history of joint pains. No history of personality changes, tremors, or dysarthria. No history of reduced daily urine output. No history of impotency or decreased libido. No history of pruritus or skin rashes. Past history. There is no past history of jaundice or any long-term hospital admission. There is no history of blood transfusion, tattooing, or injected drug abuse. There is no history of patient was never treated for tuberculosis, diabetes, hypertension, asthma, or any other prolonged illness. No past surgical intervention or hospitalization. Personal history. Patient consumes vegetarian diet, has a weight gain of 5 to 6 months in the last 1 month. He also complains of decreased appetite in the past 2 to 3 weeks. He has been consuming alcohol since 25 years, about 200 ml whiskey per day, does not smoke. The patient frequently skips dinner after taking alcohol. There is normal bowel and bladder habits. The sleep is normal. Patient sleeps with 3 to 4 pillows in propped up position. Medication history. The patient is currently not under any medication and there is no known allergy to any drug. Family history. There is no history of similar complaints in the family. No history of tuberculosis case in the family. Sir, the summary. My patient, a 45-year-old gentleman, is a chronic alcoholic and has presented with abdominal distension for 6 months, pedal edema and breathlessness for 15 days, and jaundice for 7 days. There is no history of any bloody vomiters, dark terry stool, altered sleep-phase cycle, or irritability. Based on the history, the most likely cause of presentation is a chronic alcoholic liver disease with ascites. Uh, However, other differentials which I would like to exclude in examination and investigation are autoimmune hepatitis, non-alcoholic fatty liver disease, chronic liver disease post-chronic hepatitis, Hep B or Hep C, hemochromatosis, and Wilson's disease.
Okay, Matthew, please once again you just show your slides from the starting to
Yes.
everyone. If any case in someone has missed something, so never say that patient's particulars. Okay.
Okay,
Are
sir.
you able to? I am audible?
Yes, sir. Yes.
So never say patient's particularity. It's the patient's demographic profile.
Okay, sir.
Always it is the and you start with you start your history in a flow, not in the stop gap. So it should be like this. I am presenting the case of my patient, because
Okay.
over here you are the treating doctor and patient has presented to you. Well, the scenario is the patient has come to you, you have taken the history and you are his
Yes.
doctor. Once you are done with it, you are presenting now the history to someone else. So
Yes,
this
sir.
should be like this, that I am presenting the case of my patient, Mr. ABC, who is 45-year-old gentleman
Mm.
who is educated up to the 10th standard. He's resident of Shadra, Delhi, and he belongs to upper middle source. This social status should not be mentioned in the demographic profile. It should be mentioned in the somewhere else. Okay?
Okay,
And
sir.
he presented to the OPD for chief complaints. ऐसे करके.
Yes,
It
sir.
should be in one line, in a one flow.
Yes, sir.
Okay? And the most important is when you present the history to someone else and in your examiner, when you say that I am presenting the case of my patient, so
Yes.
it sounds good also. और फिर
Okay.
एग्जामिनर को भी पता चलता है कि आपने केसेस प्रेजेंट किए हैं इसके हॉस्पिटल में या वर्ड पोस्टिंग में.
Yes.
दैट्स मोर
Okay.
इम्पोर्टेंट. ओके.
Yes, sir.
So it's in a one line, in a one sentence, and containing each and
Mm.
everything.
Okay, sir.
ठीक है.
ठीक है, sir.
Okay. Then your go ahead. Your chief complaint is abdominal distension, 6 months, 15 days. Go ahead.
Yes.
Go ahead. Next.
Yes.
It's this thing. The patient is chronic alcoholic since past 25. This should not come over here. It should be like
Yes, sir.
histopathology illness should be like this. The patient was apparently well 6 months back
Okay,
when
sir.
he or she started to notice abdominal distension.
Okay,
How
sir.
did he notice the abdominal distension first?
Sir, sir, he noticed abdominal distension means it was insidious in onset. He cannot exactly tell.
What is see, if I'm going to develop abdominal distension, there has to be some telltale signs or symptoms,
Yes, sir.
uh,
Sir,
and,
yes.
and, that- and
Yes, sir.
that's why I will notice that. Okay,
Okay, sir. Sir
it,
means
it's just
he
like
can tell that he's while wearing his trousers, the buttons are getting tight or something like that. He can complain like that.
okay, okay.
Yes, sir.
This you should have come up with in the history in the layman
Yes, sir.
language only, but you should have that it was incident onset and he complains of this thing that while wearing his shirts it is getting the buttons are getting tighter and tighter every day.
Yes. Okay,
Okay,
sir. Hmm.
so that should come into your history. How the patient notice this, like in the jaundice. I can't see my jaundice unless I see in the mirror.
Yes, sir.
Okay, so
Yes.
that's how you have to say that patient note अगर jaundice के बारे में ही बोल रहा है तो patient notice jaundice either by himself or someone has told him that
Someone.
your eyes are getting yellowish. Okay, so these are layman
Yes.
terms and you should use these layman terms in the history of present illness.
Okay, sir.
Okay, it should not be like this history of presentation should be the detailed one, not concise one. Okay, for
Yes,
every
sir.
symptom, and it is insidious in onset and gradually progresses associated with heavy discomfort. ठीक है, ठीक है. And this no history ना, no history should not come over here. No
Okay.
pain or no fever, no. This should come at the last. See the
Negative history. Okay, sir. Last
yes,
makes.
the first there should be the history of present illness. This should contain all the chief complaints in a detailed manner. That's it. जो चीफ
Okay,
कंप्लेंट्स हैं उसकी उनको उनको डिटेल में बताना है. और वैसे हिस्ट्री क्लास होती है ना 9th 10th में, जैसे हम हिस्ट्री क्लास पढ़ते थे, तो डिटेल में पूरा अच्छे से
हाँ.
बताना है उसमें. आफ्टर दैट you have to present whatever is the positive history. See, after that you want to rule out something, so you have asked
Yes.
for pain or you have asked for fever. If fever is
Yes.
there, it becomes positive history. It should come first.
Yes, sir.
All the positive history should come first, and then the negative histories.
Okay, sir.
Okay.
All negative history at the.
At the end, at the end
Yes.
of your history of present illness, the pattern of history of present illness should be is like this. The first, you have to address all the chief complaints in a
Yes, sir.
detailed manner, and then you take history for your whatever the complications, ruling out some this other etiology or whatever it is. You take history. If it comes out to positive, then it should come first. If it comes out negative, then it should come last.
Okay.
But like all the negatives in the last, all the positive in the first. Okay.
Okay, sir.
Next slide.
Yes, sir.
ठीक है. Okay. Next slide. Now, the history of abdominal swelling is of long duration of 6 months.
Yes, sir. 6 months.
So, in last 6 months, how many times before he presented to you, he has gone to somewhere else? It can't be just once.
Okay, sir. So means we have prepared a hypothetical case, so I thought only once it will be okay.
नहीं, तो that even in the hypothetical also, can you
हाँ.
imagine you are getting your abdominal distended, you are being troubled by that,
Yes.
okay, and you are
Hmm.
just visited once in 6 months to a practitioner.
Yes. Okay.
ऐसे ही होता है ना, वे
हाँ हाँ
एक बार ही जाएंगे, नहीं आराम आया 6 7 दिन में, या तो उसी डॉक्टर के पास जाएंगे या फिर दूसरा बदल लेंगे, फिर नहीं
हाँ
आराम आया तो फिर तीसरे के पास जाएंगे.
हाँ.
ओके, तो
यस सर. 6 महीने तो 6 मंथ्स बहुत ज़्यादा है वैसे भी.
6 months बहुत ज्यादा है ना.
हाँ सर.
ये आपको बताता है कि even if in a real scenario also, if someone tells you like this, then there is something fishy. Then you have to poke it out also from the patient. You have to again ask the leading questions. Again ask the leading questions. Many of the patient will conceal the alcohol history from you, but you have to have some skills or some questionnaire. जैसे जब तक प्रैक्टिस नहीं करोगे तब तो वो उसको बार बार लीडिंग क्वेश्चन करने पड़ेंगे, निकालना पड़ेगा उससे
हाँ हाँ.
जो भी हिस्ट्री होती है. तो आप बता दे तो अच्छी बात है. ठीक है, चलो. फर्स्ट नोटिस फेस इन द बायलेटरल फुट. हाउ स्वेलिंग, स्वेलिंग उसने कैसे नोटिस करी?
सर स्वेलिंग सर मतलब इट वाज मोर एट द एंड ऑफ द डे मतलब. और
It was more at the end of the day. आज
हाँ.
मैं how suppose you get the swelling in your legs, how will
यस
you
सर.
appreciate it? It will not cause pain to you.
यस सर.
Why
यस
will you notice that?
सर. सर द स्लीपर्स माइट गेट टाइट और समथिंग लाइक दैट.
Yes, slippers might get tighter, or it will leave its imprint on the skin after removing the after wearing the slippers for some time. And when you remove it, it will leave the imprint on the foot.
यस सर.
Okay, or while you are wearing your socks, you notice that the limbs are getting heavy. So not every day, no, not every time you see your limbs
यस
like
सर.
this.
यस
Okay,
सर. वैलिड.
so that you should say in your history.
ओके सर.
it's gradually progressing without progressing. चलो, और यू कैन से इट्स नो हिस्ट्री ऑफ, नहीं है इसमें। अगर आपको ये एक चीज बोलनी भी है, इफ यू वांट टू स्पीक
हाँ
इट लाइक दिस, इट शुड नॉट बी लाइक द नो हिस्ट्री ऑफ फेशियल swelling or puffiness. You say
yes
now the swelling has progressed till knee joint, and it is not associated with any facial or facial swelling or puffiness or any calf pain or any scrotal swelling or any. So it's simply association और
yes
अदर
yes
हिस्ट्री, नो हिस्ट्री
association
बोलना ही, हाँ नो हिस्ट्री बोलना ही
हाँ
है तो वो लास्ट में बोलना है।
हाँ हाँ सर अच्छा
ओके,
yes सर
ठीक है, आगे बोलो। आगे नेक्स्ट नेक्स्ट।
yes breathlessness
Breathlessness, the breathlessness part is okay, you have explained everything. And
yes
the right from the starting to, so initially breathlessness was after 500, now it has progressed even over 10. So it's okay, and there is जो orthopnea, ठीक है।
yes
नेक्स्ट, अगेन द हिस्ट्री ठीक है, नो हिस्ट्री बाद में बोलना तो कोई बात
हाँ
नहीं।
सर
नेक्स्ट, अच्छा, this one is again the jaundice. How
yes
did the patient noticed? Whether
so
someone else has told him
someone
or
else
he
told
has
him
noticed?
in the
Someone
morning
else has told him. Huh?
yes so someone else his wife told him
Okay,
I
so
don't think so
that should come
that
on that should come in the history.
yes
Now come to your the differentials.
sir provisional is sir chronic alcoholic liver disease with ascites and other differentials are these
Other differentials?
sir yeah autoimmune hepatitis no non-alcoholic fatty liver disease or chronic liver disease with post chronic hepatitis
So why are you keeping your first differential as chronic alcoholic liver disease?
sir there is a significant history of chronic alcohol consumption for 25 years
Hmm.
so and sir there is also a long history of abdominal distension and we also asked him that whether he was whether he suffered any jaundice or any hospitalization long term long before like before 10 12 years so
Hmm.
the, so then in that case uh, it will come lower the chronic hepatitis due to infective causes will come lower down in the list yes.
So what is the natural course of any chronic alcoholic liver disease?
Sir, natural course, sir. First of all, there is hepatic steatosis. Only fatty liver is there. So in that
Yes.
state, sir, there is only sir. There is it can be mostly asymptomatic, or there can be only mild vague discomfort or little bit of heaviness in the abdomen, and there is no and sir, after that there is a stage of alcoholic steatohepatitis, so where there is hepatitis as well, and patient might have constitutional symptoms like fever, malaise, sir, and little joint ache and jaundice as well,
Hmm.
sir. And
आगे?
sir, उसके बाद sir alcoholic, sir, then it goes for stage of cirrhosis, and cirrhosis it is a long term process around 10 to 10 years and when it progresses and there is distortion and shrinking of the liver
Okay.
progressively yes sir.
So does your does your case goes well with this course of the alcoholic liver disease? It says that there is steatosis on in the initial stage, and then steatohepatitis. Okay, and in steatohepatitis phase, patient will have the all the constitutional symptoms as well as mild jaundice or maybe jaundice,
Yes
moderate
sir.
jaundice also. So where is that phase in this case?
Sir, that we asked the patient but he could not tell any long term hospitalization
Long
so
term
but
hospitalization होता है ना, steatohepatitis is
मतलब past
it
history
is a
jaundice का
mild
बोलिए
hepatitis, long term mild hepatitis.
Yes,
See, what
yes.
happens is धीरे धीरे उसको hepatitis फिर रहेगा. It's not like in
Uh,
acute hepatitis, steatohepatitis.
yes, sir.
ठीक है? And then there is another thing is acute alcoholic hepatitis. When patient take too many of alcohol, the consumption is more. Suddenly patient will get acute
Yes.
alcoholic hepatitis.
Alcoholic
And
hepatitis.
in those case, patient will have the symptoms of jaundice and all the features of hepatitis. Okay,
Okay, sir. Yes, sir.
so that phase is not there in the in your history. So how can you say that it's only this thing, alcoholic liver disease?
Uh, सर मीन्स ही इज अ क्रॉनिक अल्कोहलिक एंड सर इतना पुराना हिस्ट्री सर वो करेक्टली बता भी पाएगा या नहीं वैसे
If I say that it's
तो
it's
कैसे
it's a
पॉसिबल
hepatitis C related chronic liver
यस
disease. In hepatitis C, 70% of the patient will not have any history of acute hepatitis,
यस यस मोस्ट ऑफ
and
देम आर क्रॉनिक हेपेटाइटिस
most of them
यस
are chronic hepatitis, and chronic hepatitis will not have any symptoms.
यस सर
A patient of chronic hepatitis C will not have any symptoms.
यस
उसको
सर
पता भी नहीं होगा. Have you seen so
हाँ
many of patients? So many of patients came to us for with in the भाई उन्होंने ऐसे रूटीन टेस्ट करा लिए उसमें उसका हेपेटाइटिस सी पॉजिटिव आ गया.
यस
They
सर
have no symptoms.
यस सर
Slowly, they gradually progress to a stage of cirrhosis, and then they started to develop symptoms of this jaundice,
ओके
mild jaundice, and
यस सर
upper GI bleed, all these things. So it
यस
goes more with that.
यस सर यस सर यस सर ऑलवेज
Just
अल्कोहल विल
mere,
नॉट कॉज अल्कोहलिक लिवर
just mere history of just the presence of mere history of alcohol intake does not make that patient is having chronic alcoholic liver disease. You
यस
have to see how much alcohol he has taken, what is the strong or how much intake is that. Okay. Then whether this alcohol intake corroborates with your case history.
यस
Okay. See,
यस
the etiology, the case might be the case is of chronic liver disease ascites, but etiology you have to come with the only history. कैसे उसकी सीक्वेंस रही है सिम्टम्स की. अगर
ओके
पहले जॉन्डिस आता 6 मंथ्स या से 3 इयर्स पहले जॉन्डिस आता, उसके बाद
हाँ
में जॉन्डिस थोड़ा सबसाइड हो जाता, लो लेवल का जॉन्डिस रहता, एंड आफ्टर दैट 6 months or 12 months or 2 years he developed abdominal distension, then we would have easily said that it is alcoholic liver disease, because उस टाइम पे जब 2 years पहले जब उसको जॉन्डिस हुआ तो that is because of alcoholic hepatitis, that
हेपेटाइटिस
hepatitis, and then the stage of steatohepatitis started, and now patient has developed full blown cirrhosis. That stage is missing in your history.
यस यस
Okay, are you getting my point?
yes sir I got
See,
sir
the
means we
sequence
have
of
to include a stage of hepatitis where there is
ha
jaundice
ha. So
two
that
to
should
three
come
years
up.
before
So you need to ask the question from the patient.
yes sir
That I will give you any other example also. What is the natural course of sequences in a case of you are getting too much of noisy background. Where
yes
are
sir
you?
sir little bit noise I am closing the window
Okay. So how a case of viral hepatitis presents? Acute viral hepatitis. Do you know the sequence or natural course of a case of acute viral hepatitis?
is it okay now
Is it okay now? So, do you know the natural course of sequences in a case of acute viral hepatitis? What happens in acute viral hepatitis?
Sir, in acute viral hepatitis, sir, initially there is a stage of acute hepatitis uh, where after 1 to 2 weeks there is onset of jaundice, and usually it resolves. Usually hepatitis B, and usually it is of a short duration and it is self-limiting. But if it is chronic hepatitis, then the symptoms will persist for more than around 6 months, and uh,
Yes.
after.
So,
Yes, sir.
so a case of acute viral hepatitis will present you for present with fever, 4 to 5 days or 6 days or 7 days of fever, and once the fever subsided, after that jaundice develops.
Yes,
Okay. So this is the correlation. Similarly, a patient of liver abscess,
yes,
he will also
yes,
present with fever and jaundice. Both cases
yes,
acute viral hepatitis and liver
yes,
abscess. Both will present
yes.
you with fever and jaundice.
Yes, yes.
And malaria also. Malaria sometimes will present you with fever followed by jaundice. But the
Yes,
only differentiating point from acute viral hepatitis from the liver abscess or the malaria or some other infection is that in viral hepatitis, the jaundice comes after the fever has subsided, and jaundice then will remain for a short duration, maybe 2 weeks, 3 weeks, and then it will subside. So uh, this is the sequence. Similarly, it happens in the alcoholic liver disease also. Okay, so you have to analyze the sequence also.
yes.
This doesn't. Acha, first thing is. Next thing is, why are you saying that this is a case of a chronic alcoholic liver disease?
Sir, only because of history of alcohol consumption. I do not think.
Just because of alcohol. I am saying this is not a case of cirrhosis. To me, it looks like a case of dilated cardiomyopathy.
Yes, sir. Sir, for that, sir, we have taken a negative history of
तो
dyspnea
उसमें
and uh,
तो डिस्निया क्या है तो सही इसमें ऑर्थोपनिया की हिस्ट्री है बड़ी अच्छी
नहीं सर,
ऑर्थोपनिक
सॉरी
हिस्ट्री है
dyspnea नहीं सर, palpitation and सर चेस्ट पेन के लिए लिया था history।
तो
तो बाकी
पैल्पिटेशन
yes,
नॉट एवरी पेशेंट चेस्ट पेन तो
with
होता ही नहीं है डायलेटेड कार्डियोमायोपैथी में
yes sir।
हाँ
Sir,
palpitation की
the,
patient might not give you the history but there is a strong history of orthopnea
yes sir,
breathlessness increased on lying down and he used to take 4 or 5 pillows to sleep
yes
that's a
sir.
strong history of
So
orthopnea
then sequence of the symptom is also important. Like for dilated cardiomyopathy, there will be first swelling will appear in the legs, then it will
वही तो हुआ है
progress to। नहीं सर,
वही तो
इसमें
हुआ है
तो इसमें एसाइटिस पहले है सर सबसे।
okay इसमें
तो
ascites पहले है so you think that because ascites has come first hmm, that's why
सर
the
आई
patient has dilated cardiomyopathy then why this patient is having breathlessness orthopnea
sir, it might be because patient is having means it is tense ascites and it is compressing the diaphragm.
okay so that you think is the cause of breathlessness
Breathlessness, yes sir.
so that can be understandable when the patient is sitting why is having breathlessness on walking or dyspnea on exertion
Uh, yes, sir, that is difficult to explain.
hmm?
Yes, sir. So I wrote this so means to show the progression of breathlessness. So I thought that his ascites will progress to more, and then his breathlessness
No,
will
no,
also increase.
ascites can give you feeling of breathlessness while sitting or while lying down. That's
Yes, sir.
true.
Yes,
Okay, that's true, and that you can explain from it. But while walking, why an ascites will cause breathlessness?
yes, sir. Directly means it will not cause on. It will cause more on lying down if it is
No,
because of
more on lying
ascites.
down, na? Because
Yes, sir.
then only it will compress the diaphragm. Once you are
Hmm.
standing up, the all the water will goes down. So diaphragm
Yes.
is now free.
Yes, sir.
Hmm?
Yes, sir. Yes, sir. It can, in that way, it can be due to cardiac causes.
The way you have presented the breathlessness history, that he is having dyspnea on exertion, he is having
Yes.
orthopnea. So it looks like a case of cardiac disease. Might be dilated cardiomyopathy. Alcohol is one of the reversible
Causes,
causes of
yes, sir.
dilated cardiomyopathy.
Dilated pulmonary. Yes, sir.
It might not be cirrhosis. It is dilated cardiomyopathy.
Yes, sir. That
And
can be
then
caused
patient is
by
having peritoneum also. That also comes in dilated cardiomyopathy
failure of
or an
diaphragm. Yes, sir. Or heart failure, something. Yes. It can show
heart
cardiac
failure.
causes. Yes. It can come in cardiac.
So that I mean, you have taken a hypothetical case, but I am
Yes, sir.
analyzing your history,
Mm-hmm.
whatever history you have presented to me. So the cirrhosis is one possibility. I
Yes.
totally agree. But dilated
Yes.
cardiomyopathy should be the second possibility in this case.
Yes, sir. Yes, yes.
And definitely should be, you have an etiology, you have the symptoms,
Mm.
you have a case which is likely to have this kind of symptoms.
Yes, sir. Yes. It is fine.
Any other possibility you think?
Sir, any other uh,
Now,
sir,
apart from
other
cirrhosis,
causes? Yes, sir. Other post-sinusoidal causes can also cause similar symptoms. So post-sinusoidal causes of portal hypertension.
that
Sir,
only that is
sir,
this वो क्या होते हैं
yes,
post sinusoidal causes क्या होते हैं?
so post-sinusoidal causes are, sir, like in the liver, there, sir, in the hepatic veins there can be Budd-Chiari syndrome, sir, but that is not possible here because then patient will have tense abdomen because of tender hepatomegaly. It can be inferior vena cava veins, but it is rare cause,
Hmm. Hmm.
and
Hmm.
there can be heart failure and cardiac tamponade at cardiac level,
Hmm.
which can
तो
cause portal
इसमें
hypertension.
इसमें से कुछ हो सकता है?
Sir,
कार्डियक टेम्पोनार्ड हो सकता है इस पेशेंट को?
सर कार्डियक टेम्पोनाट तो सर सडन ऑनसेट एक्यूट ऑनसेट होगा वो तो लेस
ओके.
लाइकली तो डायलेटेड कार्डियोमायोपैथी चाहिए सर लेकिन देन सर देन ऑन एग्जामिनेशन वी विल गेट हेपेटोमेगाली एज वेल
वो तो एग्जामिनेशन में होगा ना, ये तो हिस्ट्री की
हाँ
बात
हाँ
चल रही है
हिस्ट्री
अभी.
में नहीं सर ये सर
Hmm.
हिस्ट्री में तो सर फिट होता है
Why can't be it's a case of chronic CCP, chronic constructive pericarditis?
यस सर हाँ क्रॉनिक कंस्ट्रक्टिव पेरिकार्डिस इट कैन आल्सो बी यस
क्या होता है chronic constructive pericarditis में?
सर सर chronic constrictive pericarditis sir there is progressive fibrosis and exudate in the pericardial chamber and because of which there is reduced expansion of the heart in diastolic phase so there is
हाँ.
raised central venous pressure
ओके, तो रेस सेंट्रल प्रेशर होगा तो क्या होगा?
so then sir raised central venous pressure can cause cirrhosis it can cause hepatomegaly splenomegaly portal hypertension and it can also
Portal
if
hypertension? No, 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 you're taking it wrong. You're taking it wrong, Matish. See,
yes
एक उसका जो कॉम्प्लायंस है हार्ट का वो रिड्यूस हो गया.
वो
राइट
कम
हार्ट
हो
जो
गया
है उसका राइट हार्ट फेलियर होगा. वैसे
हाँ
बाइवेंट्रिकुलर फेलियर होना चाहिए होता है, लेकिन टू स्टार्ट विद इट इज द राइट हार्ट फेलियर. तो
yes
पेशेंट विल प्रेजेंट विद द फीचर्स ऑफ राइट हार्ट फेलियर जो इसमें है. ब्रेथलेसनेस है,
yes
दिस थिंग dyspnea regression है, ascites है, pediledium है. These are all the causes of these are all the symptoms of right heart failure.
yes yes
Only thing you cannot explain with this is the jaundice, which
jaundice
you are not talking about. Dilated cardiomyopathy मैंने तुमसे डिस्कस किया. Why patient of dilated cardiomyopathy will have the jaundice?
yes sir jaundice so jaundice sir it will be then it will not be present there so
Hmm?
so jaundice means in dilated cardiomyopathy it is less likely
Less likely. So when I am saying you that this is a case of the dilated cardiomyopathy, what's are points in favor and what's 0.2 seconds, you should have come up with that why patient of dilated cardiomyopathy, there is no reason the patient will have jaundice.
Yes.
Can a patient of DCMP have jaundice?
Sir, he can have really because there is raised uh, so there is raised central venous pressure. It can cause hepatocellular failure. Means I have read, but I
It will
cannot. I don't know the exact
no
explanation.
no 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 no. It cannot cause hepatocellular damage.
I don't know. Sir.
The only
So,
time with the only thing we can understand when we get the jaundice in a case of cardiomyopathy is when the patient is having shock, and because of shock, patient
yes,
will
sir.
develop ischemic hepatitis.
अच्छा okay. Yes, sir.
Okay,
Ischemic hepatitis.
तो हाँ, तो अगर इस कोई भी कार्डियक कोज में जॉन्डिस यूजुअली तभी आता है जब
Hmm.
इस्केमिक हेपेटाइटिस डेवलप हो, वो शॉक में होता है. ओके,
Yes, sir.
चलो
Okay.
नेक्स्ट आगे करो. प्रोसीड टू दी योर एग्जामिनेशन.
Okay, sir. Sir,
सर
examination will be
नेगेटिव हिस्ट्री,
sir negative history.
नेगेटिव हिस्ट्री दिखाओ. हाँ, नेगेटिव हिस्ट्री दिखाओ.
Yes.
व्हाई हैव यू टेकन हिस्ट्री ऑफ जॉइंट पेन्स?
Sir, joint pains, sir, because of sir, these are rare causes for chronic cirrhosis. Sir, joint pains in case of sir hereditary hemochromatosis or in case of autoimmune hepatitis.
ओके, और स्किन रैशेस?
Sir, skin rashes in case of sir, if it is less likely here because he is a male patient, but in case of primary biliary cirrhosis,
ओके
particularly in this age group, it will be present.
ओके ओके, ठीक है, बाकी तो ठीक है, वो सेल्फ अंडरस्टूड है. चलो एग्जामिनेशन पे चलो.
Okay, sir. Sir, examinations will be presented by Mehak. She one roll
महक,
number one
सो
one. Yes, sir.
रोल
I will. Yes, sir. You just unmute her. I will show her slides.
महक.
Mehak, yes, sir.
महक महक गुप्ता.
Yes, sir. Mehak Gupta. Yes, sir.
महक, unmute yourself.
Good morning, sir. Am I audible?
Yeah, you are audible now.
Sir, can you please make me the presenter?
Okay. Now you are presenter. Mahek, you are self muted.
Is my screen visible?
No, no, not yet.
Sir, is my screen visible now?
Not visible. Okay, your screen is not visible.
Sir, is it visible now?
No, not yet. Yeah. Now it's visible. Ma'am, now it's visible.
Okay, sir. I will be presenting the examination part. General physical examination. Patient was conscious, cooperative, well-oriented to time, place, and person. Examination was done in well-lit room with patient's consent. Vitals. Pulse 64 beats per minute, regular, good volume, normal character. Blood pressure 110 by 70 mmHg measured in right arm in supine position. Respiratory rate 30 breaths per minute. Thoracic temperature, he is afebrile at time of examination. There was no elevated GBP. Weight of the patient 52.2 kg, height 163 centimeters, and BMI 19.64 kg per meter square. Head to toe examination. A patient is emaciated, lean and thin built with poor nutrition and hydration status. Hair thinned out, brittle and sparse. Eyes icterus present. Pallor could not be appreciated due to icterus. There was no case of facial ring. A facial pallor was present.
Mehak.
Yes, sir.
Hello.
Yes, sir.
Mehak. प्रेशर
Yes, sir.
केएफ कैसे देखते हैं?
सर ऑफ्थाल्मोस्कोप से देखते हैं.
ऑफ्थाल्मोस्कोप से या किसी और चीज से?
सर टॉर्च लाइट से भी देख सकते हैं.
तुमने तो यू हैव पास्ड आउट ऑफ ऑफ्थाल्मोलॉजी. केएफ रिंग्स
Yes, sir.
देखने के लिए स्लिट लैंप एग्जामिनेशन करना पड़ता है.
Yes, sir.
सर हम मतलब पेशेंट को ऑफ्था के लिए रेफर कर देंगे एंड देन वो बता देंगे कि
नहीं तो ये तो तुम प्रेजेंट कर रहे हो ना. आई एम जस्ट पॉइंटिंग आउट दिस बिकॉज दिस मिस्टेक यू विल मेक इन योर एग्जामिनेशन आल्सो.
ओके सर.
When you are presenting your अगर तुम्हें कोई एग्जाम में ऐसा केस मिला तो you will say that there are no KF rings. Then examiner will ask you, okay, do this slit lamp examination. Will you do it? Will you be able to do over there?
No, sir.
No, na? So remember this thing. KF rings are seen only on slit lamp examination. You cannot appreciate those things with ophthalmoscope or a torchlight. So it's not a bedside examination. Okay.
Okay, sir.
Okay. So don't do mistakes like this in your exam.
Okay, sir.
Okay. Go ahead.
Head hollowing of temples and bilateral parotid enlargement evident. Oral cavity, poor dental hygiene, no cheilitis, no glossitis, no angular stomatitis, KD is present and feature hepaticus present. Chest wall, 6 spider nevi seen on upper chest, gynecomastia present. There was no scratch mark over trunk. Palmar erythema present. There was no flapping tremors, no contracture or nail changes seen, no clubbing. Bilateral pitting edema present, extended from foot up till knees. Sacral edema also present. There was no cyanosis, no lymphadenopathy. This is the image of a spider nevi and palmar erythema.
So what you explain, please, can you explain the spider this palmar erythema in this picture? What it looks like?
Yes, sir. There is redness over the thenar and the hypothenar area. Mostly palmar erythema involves thenar and hypothenar area. It can sometimes be present in sole of the patient also. It is due to hyperdynamic circulation.
So the important thing is over here the thenar and hypothenar region may you able to see the congestion or redness. Okay, but the
Yes, sir.
central part is always clear.
Straight.
Okay, so I have asked many students. They say that all the palm is red, all the palm is red, but it should be noted to everyone that in palmar arrhythmia, the redness will be in the thenar and hypothenar region mostly, or in the base of the digits. But the central part is always clear. Okay, so go ahead. Next slide. Mahek, I'm audible.
Sir, am I audible?
And now you are audible. Please go ahead.
सर एक्चुअली मेरा नेट ब्रेक हो गया था सर आपने लास्ट लाइन क्या बोली थी आई कुडंट हियर दैट
Nothing. I was just explaining this picture that this picture you can see all the thenar and hypothenar and the base of the digits are red, but the central part is clear.
yes sir
Okay. So there
yes
is
sir
always a central clearing in palmar arrhythmia. If whole of the hand is red, that doesn't mean palmar arrhythmia.
okay sir
Okay.
a local examination inspection lips appear normal with no evidence of cracks fissures or scars teeth have multiple caries tongue appear normal there are no ulcer or patches on the palate or mucosa abdomen examination the abdomen is fully distended flanks are full uh, umbilic umbilicus is everted, it is downward displaced and transverse slit. This is known as Taniol sign. Skin appears shiny with no stria or scratches noted. No discoloration of skin seen, no hyperpigmentation. All abdominal quadrants move equally with respiration. 4 engorged veins noted around umbilicus. There is no visible pulsations or peristalsis. No scars or sinuses seen on head raising test, no divarication of recti seen, hernial sites are free. This is the image of transversely slit umbilicus which is seen in ascites and the next image is of the dilated veins around umbilicus. In palpation, palpation is done in supine position with both lower limbs flexed and hands by side of patient exposed from Xiphi sternum to just above inguinal ligament with semi-flexion of hip and knee joint. In superficial palpation, all the quadrants, there was no guarding and rigidity and there was no tenderness and there was no local rise of temperature on anything. Abdominal girth was 95 centimeters. ZV sternum to pubic symphysis was 42 centimeters. And ZV sternum to umbilicus was 24 centimeters, while umbilicus to pubic symphysis is 18 centimeters. This shows that the umbilicus is displaced downwards.
What is the significance of abdominal girth?
Sir, as such, there's no significance during the examination part, but later on, when the patient will be on management, then by abdominal girth, we can see whether the patient is responding, whether the ascitic fluid is decreasing or not, patient responding to
Okay.
diuretics or not.
Very good, very good. Okay. So continue.
Right and left ASIS to umbilicus is 18 centimeters each. That means the umbilicus is not shifted laterally.
Okay. Next.
Uh, Direction of flow of blood in engorged vein is away from umbilicus, both above and below. Fluid field was present. On deep palpation, liver was not palpable. Spleen is palpable 2 centimeter below left costal margin. By dipping method, it was non-tender. No other palpable mass. Renal angle is non-tender. PR and testicular examination was not done.
Mm.
Percussion. Liver, upper border of liver dullness is percussed at right fifth intercostal space along mid-clavicular line with lower border at costal margin. Liver span is 13 centimeters. Spleen, by Casel's method, dullness is observed in the ninth intercostal space in anterior axillary line. By Nixon's method, the spleen extends 9 centimeter above the left costal margin. And by in Traube space, there was dullness in Traube space. A shifting dullness was absent. On auscultation, there was no bowel sounds heard, no venous hum, no bruit. Other system examination, cardiovascular system, apex beat in left fifth intercostal space, middle to mid-clavicular line, normal heart sounds, and no murmur. Respiratory examination, midline trachea, bilateral equal air entry present, normal vesicular sounds on lung field, no added breath sounds. In neurological system examination, higher mental functions intact, no focal neurological deficits present, no involuntary movements, no flapping tremors. So summary, my patient, a 45 years old gentleman, a chronic alcoholic for 25 years, has presented with abdominal distension for 6 months, pedal edema and breathlessness for 15 days, and jaundice for 7 days. There was no history of blood vomiters, dark tarry stools, altered sleep-wake cycle, and irritability. On examination, features of liver cell failure like spider nevi, gynecomastia, palmar erythema, and fetal hepaticus present. A patient also has pallor. A feature suggestive of portal hypertension such as ascites with visceral, mild splenomegaly, and capitulation also observed. With this, my provisional diagnosis for the patient is decompensated liver disease, probably cirrhosis of liver, with features of portal hypertension like ascites, mild splenomegaly, and caput medusae, probably due to chronic alcohol consumption. But still, differentials which will be ruled out on investigations are non-alcoholic steatohepatitis, autoimmune hepatitis, and chronic hepatitis C.
Okay. Why are you keeping non-alcoholic steatohepatitis in your differential?
Sir, because on the basis of history and examination, we cannot rule out this just on the basis of history that patient is alcoholic. We cannot say that patient is not having NASH because uh, non-alcoholic steatohepatitis is a very common cause of cirrhosis
Yes,
nowadays.
it's a very common form of cirrhosis. Okay, but non-alcoholic steatohepatitis will, do you think will have ascites, will have pedal edema, will have jaundice, all these features?
सर लाइक सिवियर स्टेजेस में मतलब स्टेजेस तो उसके भी वही होते हैं कि पहले फैटी स्टेज देन हेपेटाइटिस स्टेज एंड
Oh,
देन
that is
सिरोसिस
what.
स्टेज.
See, there are three stages: steatosis, steatohepatitis, and cirrhosis.
Yes,
Okay,
sir.
so this steatohepatitis is in the middle phase.
Yes, sir.
Okay, so do you expect a patient? Okay, forget about this. You said that there are features of portal hypertension.
Yes, sir.
Okay, so what is the cause of that portal hypertension in this patient?
Sir, in this patient, the patient has cirrhosis. So there is fibrosis. There are
So you think,
degenerating
so you think this portal hypertension is because of cirrhosis. Okay,
Yes, sir.
Anna? So
Yes, sir.
does anywhere it is mentioned that portal hypertension can be caused by steatohepatitis?
Uh, no, sir.
Hmm? No, you are
No,
yourself is saying that you are yourself is saying that patient is having portal hypertension. So this post-portal hypertension is most likely because of cirrhosis.
yes, sir.
If it is not because of cirrhosis, can it be because of steatohepatitis?
No, sir, it cannot be.
Cannot. See, so that's how you see it. See, the thing is, in this case, the portal hypertension is more or less obvious. Patient is having ascites, patient is having splenomegaly, which are the two key features in a key clinical findings in a case of portal hypertension:
Yes.
splenomegaly and ascites. Okay,
Ascites.
so this patient is having portal hypertension, no doubt about that. But what is the cause of that portal hypertension? It can be cirrhosis, that might be because of alcohol, that might be because something else also. But non-alcoholic steatohepatitis is a totally different entity.
Sir, like non-alcoholic steatohepatitis, like if it progress and it goes into
If
cirrhosis,
it progress,
then
so if it progress, then it becomes cirrhosis.
it's a non-alcoholic
Then
cirrhosis.
yes,
Okay, sir.
NASH will ultimately cause cirrhosis. So then we will not say that it is NASH. Now it is cirrhosis. The cause is
Okay.
NASH. Okay.
Okay, sir.
So what I am telling you is that in the stage of non-alcoholic steatohepatitis or NASH, there is no ascites, there is no portal hypertension. Okay.
Okay, sir.
Once the portal hypertension or portal hypertension develop or ascites develop, then it has already crossed the stage of NASH and now it has progressed to cirrhosis.
Okay, sir.
So there is a difference in the symptomatology and clinical findings in both NASH and cirrhosis. NASH is nothing but NASH patient will have some constitutional symptoms, plus your LFTs will be deranged.
Yes, sir.
So that is NASH. There is an ongoing chronic hepatitis going on, so that is NASH. Or you can say it in it's like a chronic hepatitis or C or B, where patient will not have many symptoms, only mild constitutional symptoms, and the LFTs will be deranged.
Okay,
Okay.
sir. Okay, sir.
In viral hepatitis, the ALT will be more than AST, and in NASH, it is equal or might be AST might be more than ALT. That's it. So these are the two differentiating points. The clinical part is that these patient non-alcoholic steatohepatitis patient will not have portal hypertension. If portal
Okay, sir.
hypertension is there, then it must have progressed to cirrhosis.
Cirrhosis.
Okay.
Okay, sir.
Why are you thinking of autoimmune hepatitis?
Sir, because autoimmune hepatitis in late stages can cause cirrhosis, so that's why I kept autoimmune hepatitis. It cannot be
In a
ruled out
case,
just on the
in a,
basis of.
or in autoimmune hepatitis in a 46-year-old male patient at this stage of his life, hmm, maybe. So the
So,
differential
matlab, female, so it is
so
more
these are
common
not
in
differentials
females.
then. No. So these are not differentials then. These are the etiologies of the cirrhosis.
Okay, sir.
Okay, the
So,
right
so,
term is etiology.
so
They,
I should
they,
write etiologies and then
yes,
I should
yes,
write
yes,
this.
yes, yes. So the diagnosis is like this cirrhosis of liver with portal hypertension, or you can say the case is the patient is a case of portal hypertension. The likely cause of portal hypertension is cirrhosis, and the etiology of cirrhosis might be alcoholic liver disease. Second, NASH related cirrhosis. Third, whatever you think, either autoimmune hepatitis or chronic hepatitis C, whatever.
Okay,
So
sir.
okay, अगर
Okay, sir.
ऐसे बोलोगे तो फंस जाओगे बच्चे। अब तुम इसमें लिख रहे हो, चलो इटियोलॉजी भी लगा लें, तो क्रोनिक हेपेटाइटिस सी तुमने लिखा है।
Yes, sir.
तो
Yes, sir.
क्रोनिक हेपेटाइटिस बी ने क्या गुनाह कर दिया, उसको क्यों नहीं लिखा तुमने?
सर मतलब सिरोसिस स्टेज पे तो मतलब
तो
सी है
बी
जो
भी करता है
माइल्ड
सी।
रहता है एंड लेट स्टेज.
नहीं, यू आर टेकिंग इट टोटली रॉन्ग। In the earlier part of his of the illness, there is a difference, mild difference between B and C. इट जस्ट दी सी में बहुत कम एक्यूट हेपेटाइटिस होता है, बी में थोड़ा ज्यादा होता है। सी का लेटेंट टाइम थोड़ा ज्यादा होता है और बी का थोड़ा नहीं, बी का और ज्यादा होता है लेकिन सी का कम होता है। बट वंस द सिरोसिस इज डेवलप्ड both are equal.
Yes, sir.
Okay, once the
Sir,
cirrhosis has developed, it might be because of C, it might be because of B, but जो ultimate illness थी वो तो हो गई ना।
yes,
अब
sir.
अब आप you cannot differentiate between Hep C and Hep B either by examination, either by history.
सर लाइक अगर हम हिस्ट्री ऑफ ब्लड ट्रांसफ्यूजन, आईवी ड्रग अब्यूज, सेक्सुअल
तो
कांटेक्ट
वो तो
इन
B
सब
से भी
से वो,
होगा। हाँ, तो
हाँ सर
अगर
वो
हिस्ट्री दोनों से होगा, दोनों ब्लड रिलेटेड है, दोनों हाई
यस
रिस्क बिहेवियर से होते हैं, दोनों ब्लड ट्रांसफ्यूजन से होते हैं, दोनों टैटूइंग से होते हैं।
सर. सो शुड आई कीप बोथ और शुड आई कीप नो वन इन दिस?
You say just say chronic viral hepatitis. Don't take it as C or B.
ओके सर.
अगर आपको रखना ही है वायरल इज द कॉज, उसको आप क्रोनिक वायरल हेपेटाइटिस बोल दो ना। Why do you want to just specifically C? वो ये पूछेगा B क्यों नहीं, जैसे मैंने पॉइंट आउट किया। Why not B? B में तो यही सब होता है, सिरोसिस होता है, पोर्टल हाइपरटेंशन होता है, स्प्लेनोमेगाली होता है, असाइटिस होता है, ये सब होता है B में भी।
यस सर.
Hmm?
यस
So
सर.
these are what we are discussing. These are the etiologies. So, can this patient is having another disease? मतलब डिफरेंशियल्स वो होते हैं जैसे आपने डिजीज के डिफरेंशियल्स होते हैं, इटियोलॉजीज के डिफरेंशियल्स नहीं होते। सो सिरोसिस विद पोर्टल हाइपरटेंशन इज विद ascites is your one differential. Can
Yes.
you have another differential?
Sir, like sir, dilated cardiomyopathy. So in examination, it's almost ruled out because the heart
In
was.
examination, yes, the heart is
So there was
completely
no.
normal.
Yes, sir. There was no raised JBP, and there was no murmur heard, or there was no epic speed shift was
Yes.
there, and there was no
So not
cyanosis.
so not only the dilated cardiomyopathy, every cause of heart disease has been ruled out.
Ruled out. Yes, sir.
Because ultimately we have to think of the cause of the ascites. तो कोई भी कार्डियक कोज के लिए अगर ascites डेवलप होगा तो उसको राइट हार्ट फेलियर होगा, एंड राइट
Yes,
हार्ट
sir.
फेलियर होगा तो जेवीपी रेज होगा।
Yes, sir.
अगर जेवीपी रेज नहीं है तो ascites के राइट हार्ट कार्डियक कोजेस रूल्ड आउट है।
Yes, sir.
Once the JVP is normal, so the causes of ascites, the cardiac causes of ascites has been ruled out. It's
Yeah.
as simple as that. Okay. Any
Yes,
other?
sir. Sir, so there are post-sinusoidal causes like Budd-Chiari syndrome. It's ruled out because there was no hepatomegaly and there was no
नहीं
tenderness
तेरे
in
को
the abdomen.
हेपेटोमेगाली क्यों नहीं है? हेपेटोमेगाली तो है बच्चे।
नहीं सर, splenomegaly है just.
नहीं, क्या लीवर का स्पैन है?
सर 13 सेंटीमीटर. सर मतलब
नॉर्मल
12 to
लीवर
15 सेंट. सर 12 to
किसने बोला?
15 is normal.
किसने बोला 12 to 15 सेंटीमीटर होता है लीवर स्पैन?
सर मैंने नोट्स में लिखा बताओ.
किसके नोट्स में लिखा हुआ है? अभी तो पूछ रहा हूँ, कहाँ से देखा? नोट्स क्यों देखते हो? बुक भी तो होती है, हचिसन बुक है ना एक।
यस सर.
एक हचिसन नाम की बुक आती है, तुम्हारे पास है?
सर मैंने मैक्लियोड से पढ़ा था.
मैक्लियोड में भी 12 to 15 नहीं लिखा है। अगर अभी तुम लैपटॉप पे हो या किसी कंप्यूटर पे हो तो गूगल ऑन करके देखो लीवर नॉर्मल लीवर स्पैन कितना है।
ओके सर.
इट्स 10 to 12 सेंटीमीटर।
ओके सर.
है
यस सर.
इवन इफ है कितना है?
सर 6 to 12 centimeters.
So not beyond 12 centimeter. If you are saying it is 13 centimeter, then it's hepatomegaly.
Yes, sir.
उसको छोड़ो, वैसे तो 10 to 12 सेंटीमीटर इज द नॉर्मल लिवर स्पैन, ठीक है, टेक माय वर्ड्स, इट्स 10 to 12 सेंटीमीटर.
Okay, sir.
Okay,
Okay,
even
sir.
if it is, if you think even if it is normal, normal liver span is 12 to 15 centimeters, then also it is hepatomegaly in your case, because in cirrhosis it should have been shrunken. अगर shrunken होएगा तो 12 से नीचे ही होगा ना.
Yes, sir.
तो ये
हाँ, sir.
नॉर्मल है लीवर तो है, नॉर्मल है तो सिरोसिस कैसे हो गया?
ठीक है. हाँ सर, मतलब ऐसा हो सकता है ना, लाइक इन इनिशियल स्टेज देयर इज हेपेटोमेगाली इन अल्कोहलिक लिवर डिजीज, देन आफ्टर दैट मतलब अभी वो श्रंक होना शुरू हुआ है तो इट्स इन दैट स्टेज, तो वो अभी कम, ज्यादा से कम हो रहा है, लाइक मे बी.
सो
सर तो अभी वो लाइक 13 सेंटीमीटर्स पर ही पहुंचा है, तो अभी वो 12
अच्छा,
हो जाएगा. अभी 12.
you tell me the causes of portal hypertension and that hepatic causes of portal hypertension.
Sir, hepatic causes of portal hypertension, sir, there are pre-sinusoidal causes, there are post-sinusoidal causes, and there are sinusoidal causes. In post-sinusoidal causes, there is intrahepatic and extrahepatic. In
नहीं,
extrahepatic,
महक तुम बस साइनोसॉइडल बता दो.
okay. So sinusoidal causes, sir, cirrhosis is this.
Cirrhosis may be due to any cause. Any cirrhosis because of any causes is causing portal hypertension. That's true. Another causes?
Sir, schistosomiasis.
नहीं, वो तो वो होता है बच्चे, पहले वाले में होता है, प्री हेपेटिक में होता है, मतलब हेपेटिक पूछ रहा हूँ.
Sir, sinusoidal causes. Sir,
सिरोसिस
nodular
तो होगा,
degenerative. Sir,
वो तो
nodular
सिरोसिस ही हो गया, वो तो सिरोसिस ही हो गया ना.
Sir,
सिरोसिस ऑफ
malignancy.
है,
Sir, malignancy.
मैलिग्नेंसी नहीं,
Sir,
मैलिग्नेंसी तो नहीं होती.
sir, sinusoidal के causes नहीं पता हो.
सबसे इम्पोर्टेंट तो वही है. कितने केसेस देखे हैं सिस्टोसोमियोसिस के तुमने, या सुना है उसको हो गया? सबसे इम्पोर्टेंट तो साइनोसॉइडल कॉजेज ही होते हैं. उसमें एक तो तुमने बता दिया, सिरोसिस, वो चाहे अल्कोहल से हो, वो चाहे हेप बी से हो, चाहे हेप सी से हो, चाहे विल्सन से हो, किसी से भी हो, तो सिरोसिस
Sir,
हो गया. नेक्स्ट एक कॉज और बताओ.
sir, polycystic liver disease.
पॉलीसिस्टिक लिवर डिजीज में क्यों पोर्टल हाइपरटेंशन होगा? और कहीं लिखा भी नहीं है वैसे तो, पर तुम बताओ क्यों होगा.
Sir, sinusoids को अगर compress करेंगे, अगर
और साइनोसॉइड्स
तो
सिस्ट होती हैं बड़ी
sir,
बड़ी, एक होंगी, दो होंगी, चार होंगी, 10 होंगी. लिवर तो सारे साइनोसॉइड्स तो नहीं कर सकती ना वो कंप्रेस.
yes sir.
तो बुक में तो पढ़ा होगा तुमने, कॉजेस नोट्स बनाए हैं ना.
Yes sir.
हाँ, तो
Sir,
बताओ
उसमें
कॉजेस.
sir cirrhosis, sir cirrhosis दिखा था, polycystic liver disease दिखा था, nodular degenerative hyperplasia और metastatic malignant disease. सर
ये तो
कॉन्जेनाइटल
बहुत,
हेपेटिक फाइब्रोसिस होता है, बट वो
यस,
फिर
हाँ,
इंट्राहेपेटिक प्री
कॉन्जेनाइटल,
साइनोसॉइडल.
कॉन्जेनाइटल हेपेटिक फाइब्रोसिस होता है. वेरी गुड, ठीक है. और
सर ड्रग्स से हो सकता है, लाइक विनाइल क्लोराइड सार्कोइडोसिस से हो सकता है.
यस, वो सब फाइब्रोसिस कराएंगे बेसिकली, nothing else,
यस
but it's
सर.
the fibrosis which they causes, that's why they develop then cause. Anything else? One thing is very important which I want to
सर
point it out.
वीनो ऑक्लूसिव डिजीज.
वीनो ऑक्लूसिव डिजीज तो बाद वाले में, पोस्ट हेपेटिक में आता है. हेपेटिक वेन थ्रोम्बोसिस और आईवीसी थ्रोम्बोसिस और उसमें आता है उसको. If you read it properly, then cirrhosis is one cause and the next cause is alcoholic hepatitis.
यस सर.
Have you read
यस
it
सर.
somewhere?
यस सर. सर आई थॉट कि अल्कोहलिक हेपेटाइटिस विल लीड टू लेटर
Yes.
सिरोसिस, तो
So what I'm pointing out over here is that
Yes.
alcoholic cirrhosis is different entity and alcoholic hepatitis is different entity.
Okay,
Okay.
sir.
Once cirrhosis developed, the liver will shrink. Liver will shrink in a case of cirrhosis. But in alcoholic
O-
hepatitis phase, the liver is enlarged.
Okay, sir.
Okay. And alcoholic hepatitis can also cause portal hypertension.
Yes, sir.
Okay. But viral hepatitis will, acute viral hepatitis or viral hepatitis will not cause portal hypertension.
Okay, sir.
Now, you understand my point?
Yes, sir.
In hepatitis phase, any acute viral hepatitis or chronic viral hepatitis will not cause portal hypertension. It's the alcoholic hepatitis which can cause portal hypertension. Obviously, cirrhosis from any cause will cause portal hypertension. So, cirrhosis from maybe cirrhosis because of viral etiology B, C, or alcohol, or Wilson's, or something else will cause portal hypertension. But the difference is in the alcoholic hepatitis and viral hepatitis. Alcoholic hepatitis will cause portal hypertension, and viral hepatitis will not cause portal hypertension. So this patient is having a strong history of alcohol intake. He is having portal hypertension, and his liver is enlarged, according to you.
Yes, sir.
Okay, so it's not cirrhosis then; it's alcoholic hepatitis.
सर सर फिर सर लिवर enlarge is wrong because इसके अंदर CLD के भी symptoms हैं सारे. So
Yeah.
sir, patient has symptoms of chronic liver disease. So
Yes.
I think liver span is wrong. I should decrease that.
Either you reduce your liver span or you remove your chronic liver failure signs.
Yes, sir.
So whatever it's just a hypothetical case. So hypothetical case होगा तो ये सब तो होगा ही. But the only thing is what I'm telling you, or I'm saying that you must remember one important cause of portal hypertension is alcoholic hepatitis. Some patients will present to you in a stage of acute alcoholic hepatitis. Okay, they will have
Okay,
full
sir.
blown hepatitis, jaundice of 20, 25, AST/ALT in the range of thousands. ठीक है, patient will have ascites, patient will have, ये तो तुमने 13 सेंटीमीटर बताया, वो तो 15, 16, 18 सेंटीमीटर का लीवर होता है उनके पास में तो, ठीक है.
Okay, sir.
And then there is ascites also. Patient will have mild splenomegaly also. So in that case, when someone will ask you, what is your diagnosis? So if you say cirrhosis, then it's totally wrong. In cirrhosis, liver size is reduced.
Reduced.
So now the patient is still in the phase of acute alcoholic hepatitis. So the diagnosis then becomes acute alcoholic hepatitis with portal hypertension, not cirrhosis.
Okay, sir.
Okay. So when
Okay,
you are
sir.
finding in an alcoholic patients, when you are finding hepatomegaly along with portal hypertension, then it is alcoholic hepatitis with portal hypertension. And if you are finding that liver is shrunken and there is ascites, then it is cirrhosis.
Okay, sir.
Okay.
Okay, sir.
Okay. Any other cause in this patient? He is alcoholic, so lean and thin, BMI low, poor nutrition, poor hygiene. Why not tuberculosis? Abdominal tuberculosis.
So because there is no history of fever or night sweats or chills. So
So that might not become in immunocompromised state. Fever is not the commonest symptom, or fever may not be there in immunocompromised state, like in HIV, diabetics. Fever is absent. Not
okay,
all
sir. So
patients of tuberculosis will have fever. specifically immunocompromised patient, old age patient, diabetic patient, HIV patient, chronic alcoholism patients. They don't. They are in a stage of a immunocompromised state, and fever might not be there.
Okay, sir. So then
And
we will not be.
rest all symptoms can be explained by tuberculosis, abdominal tuberculosis. Splenomegaly is splenomegaly. Yeah, patient will have splenomegaly. Patient will have ascites. Patient will have jaundice in tuberculosis.
So, but the signs of chronic liver failure.
साइंस ऑफ क्रोनिक लिवर फेलियर तो अब तुमने हाइपोथेटिकली बनाए हैं, वो तो लिवर स्प्लेन्स भी गलत बताया है। साइंस ऑफ लिवर फेलियर चलो नहीं है तो इसमें से साइंस ऑफ लिवर फेलियर हटा दो।
सर फिर हम रूल आउट कर लेंगे सर इन्वेस्टिगेशंस पे।
इन्वेस्टिगेशन से रूल आउट करोगे ना तो देन you should think of abdominal tuberculosis also.
Okay, sir.
Maybe third differential, maybe fourth differential, but lower down you should have these causes also.
Okay, sir.
Okay.
Okay, sir.
My point is that ascites जब CLD का केस मिलता है, जब ऐसा सिनेरियो है कि लीन एंड थिन पेशेंट है, इम्यूनो कॉम्प्रोमाइज्ड है, ascites है, स्प्लिनोमेगाली है, जॉन्डिस है, so abdominal tuberculosis also becomes one of the important thing.
Okay, sir.
Okay. So because now you cannot rule out based on your history and examination, completely rule out based on history examination abdominal tuberculosis. You have to depend on your investigations.
Investigations.
And that's why you want to have differentials.
Okay, sir.
After history and examination, why do you want to have differentials? So that we do investigations accordingly.
To rule out.
To rule out other things we haven't ruled out in our history examination. Okay.
Okay, sir.
Even if this patient is having cirrhosis and this thing, portal hypertension, then also he can have tuberculosis.
Okay, sir.
अगर उसको सिरोसिस हो गया तो ऐसा थोड़ी कि वो इम्यून हो गया उससे ट्यूबरकुलोसिस से। ट्यूबरकुलोसिस तो सबको इम्पोज हो ही सकता है, साथ में भी तो हो सकता है ना, इतना ही ज्यादा सीवियरली इम्यूनो कॉम्प्रोमाइज स्टेट है इसको, है ना। So you have to keep this in mind. Now you tell me, how will you proceed?
So we will go for examination. Sir, investigations.
क्या करना चाहोगे?
Okay. So we will go for ALT and AST. We will go for CBC. So CBC with peripheral smear and sir, LFT serum creatinine to rule out hepatorenal syndrome. Then such we will chest X-ray.
Whenever an examiner will ask you how will you go about the patient, you have to say that we will do some routine investigations and we'll do some specific investigations. Routine investigation like CBC, LFT, KFT and all these things. Okay?
Yes,
routine investigation, CBC, LFT, KFT, blood sugar, urine, chest X-ray. These are all routine investigations. In routine investigation, जो तुम कराओगे उसमें तुम्हारा specific focus can be on LFT, can be on peripheral smear, can be on KFT also. But other specific investigations are this one. तो वो तुम्हें बताना पड़ेगा. Okay. So routine investigation को in every patient will have the routine investigations. Now you tell me the what are how LFT will help you out.
Sir, in LFT, sir, we will do AST by ALD. मतलब SGPT and SGOT ratio we will do. Sir, if the ratio is more than equal to 1.1, then it's due to then it's due
Suppose
to non-alcoholic diseases. But if it's less than 1.1, then it's due to alcoholic liver disease. So by this we can differentiate.
I'm giving one hypothetical value to you that the bilirubin is 7, total bilirubin is 7, and his AST is 600 and ALT is 400.
Okay, sir.
Okay. Now you tell me
Yes, sir.
what is this patient is having? Cirrhosis या क्या?
So 1 second. So since AST by ALT ratio is 1.5, so sir, it's more than 1. So sir, it's more than, sir. So it should be, so पता नहीं sir, more than 2 में it's alcoholic and less than 2 is non-alcoholic. So,
Okay. Still AST is more than ALT, so it goes towards
yes, sir.
alcoholic. ठीक है?
Alcoholic.
But it will not show you whether this patient is having cirrhosis or not.
Yes, sir. So for that we will do SAG, serum acidic abdomen gradient.
That will also not show you that this patient is having cirrhosis or not. That will tell you the patient is having portal hypertension.
Sir,
My question.
sir, we can do ultrasound.
Okay. Just see in cases of cirrhosis, these patients will
Yes.
not have the AST-ALT in the range of 10 times or 15 times. Cirrhotic patients have the hypertransaminases in the range of 3 to 4 times only, usually.
Okay, sir.
Why? Because all the liver cells are damaged. उनमें AST-ALT होता ही नहीं है, पहले ही निकल जाता है. अब एक क्रोनिक स्टेट थोड़ा थोड़ा जो बनता है वही बाहर होता है. समझ रहे हो? सारा तो लीवर जो है नोडुलर हो गया है, सारे तो हेपेटाइटिस जो है हेपेटोसाइट्स हैं वो डीजनरेट हो गए हैं. जो कुछ हैं जो रीजनरेट हो रहे हैं उन्हीं से AST-ALT निकल रहा है. ठीक है, तो उसमें वैल्यू इतनी ज्यादा नहीं होती. इफ यू सी वैल्यूज इन द रेंज ऑफ 600 800 1000 in the range of that means there is some acute process is going on.
Okay, sir.
Okay.
Yes, sir.
That means there's some acute process is going on. Or acute process, it can be acute alcoholic hepatitis. Since the patient is taking so much of this thing, और jaundice भी उसको अभी हुआ है 15 days 7 days पहले ही.
Yes, sir.
और स्पेसिफिक इन्वेस्टिगेशन क्या कराओगे?
सर साइटिक टैप करवाएंगे. सर उसके इन साइटिक टैप सर एक्चुअली सर जो इन्वेस्टिगेशंस है दैट विल बी टेकन बाय मिताली.
अच्छा, मिताली करेगी?
यस सर, इन्वेस्टिगेशंस एंड मैनेजमेंट.
अच्छा, अब मिताली को प्रेजेंटर बनाना पड़ेगा है?
यस सर.
ओके, आई एम मेकिंग हर एज प्रेजेंटर. मिताली फुल नेम इज?
सर मिताली श्रीवास्तव सर. बट आई वांट टू आस्क वन थिंग. Sir, so in this case, we will keep what all differential diagnosis? We will keep abdominal TB as one of the DD. Then,
yes, you should have one of your differential as abdominal tuberculosis also. Maybe lower down. See, the case what you have presented is very clear cut because you have given all the things. You might not get all this. 1 minute, 1 minute. Hello?
yes, sir.
Since you have given the signs of chronic liver failure also, portal hypertension also, splenomegaly also, everything you have given in the case. That's why it is more looking like cirrhosis and portal hypertension. But still, abdominal tuberculosis can be one diagnosis also in this case. Okay.
Okay, sir.
But if you find slightly elevated JVP or signs of right heart failure, then you can include the diagnosis of this thing, cardiac causes also.
Okay, sir.
Okay, so
Okay, sir.
अब इसमें तो jaundice भी है. इस केस में it's not every patient of cirrhosis will have jaundice or clinically appreciable jaundice.
Yes, sir.
Usually नहीं होता है. जैसे मैंने बताया ना, उनके जो AST ALT हैं वो 100, 90, 120 ऐसे होते हैं, और उनके बिलिरुबिन भी ऐसे होते हैं 1.4, 2, 2.2 ऐसे होते हैं, और जो बिल्कुल सिरोटिक पेशेंट्स होते हैं उनके.
Okay, sir.
Okay.
Okay,
So
sir.
in that scenario, you're in real life or in ward, when you get that scenario, then your differentials can be broadened. Then you can include dilated cardiomyopathy also, but always keep first possibility जो तुम्हारी strong है, जैसे cirrhosis तुम्हारी strong है, इसमें you have to keep your first possibility as cirrhosis.
Okay, sir.
And then second, whatever you think is more dominant, like cardiac cause or infectious cause like tuberculosis, or one cause can be malignancy also.
Okay, sir.
Okay, it can be hepatocellular carcinoma also, can be any other malignancy also. Okay, but
Okay,
since
sir.
in this case you have given complete picture, the spleen भी दिया है तुमने, ascites भी दिया है तुमने, liver cell failure के signs भी दिए हैं, alcohol की history भी बहुत अच्छी दी है. So now it is more condensed towards cirrhosis only. But just to generate the discussion, I just added on the dilated cardiomyopathy, then the abdominal tuberculosis, and then one possibility of malignancy is always there in this. Okay.
Okay, sir. सर अगर
So,
लिवर स्पैन डिक्रीज्ड होता तब तो हम मैलिग्नेंसी नहीं लेते ना?
नहीं, then also you can have the cirrhosis. ये बताओ हेपेटाइटिस सी से चांसेस ऑफ मैलिग्नेंसी कितने होते हैं? हेपेटाइटिस सेलुलर कार्सिनोमा होते हैं ना?
Yes, sir.
हेपेटाइटिस सेलुलर कार्सिनोमा सिरोसिस से तो डेवलप होता है.
Yes, sir. Yes, sir.
हेप सी की वन ऑफ द ड्रेडेड कॉम्प्लिकेशन इज सिरोसिस, और उसके बाद मैलिग्नेंसी.
Yes, sir.
है ना? तो ऐसा नहीं है कि सिरोसिस हो गया तो मैलिग्नेंसी नहीं होगी, लेकिन cirrhotic patient में अगर malignancy होगी तो it can have one lobed enlarge also, और
Yes, sir.
rare thing होते हैं जैसे फाइब्रोलेमिनर वेरिएंट ऑफ हेपेटाइटिस कार्सिनोमा होता है, उसमें कोई ऐसे मास नहीं बनता, बट देयर इज डिफ्यूज इन्वॉल्वमेंट, तो इट इन इनिशियल स्टेज इट कैन बी मैलिग्नेंसी आल्सो. बट यस, अगर आपको फिर मैलिग्नेंसी के कुछ और पॉइंट्स हो, सिरोटिक पेशेंट्स में मैलिग्नेंसी डेवलप हो जाएगी तो उनका लिवर एनलार्ज हो जाएगा, बट देन इट विल बी वेरी हार्ड लिवर, नॉट सॉफ्ट टू फॉर्म, then it will be hard liver. So there are telltale signs also. You have to keep all these things in your mind while addressing malignancy. But yes, cirrhosis के बाद malignancy होती है.
Okay, sir.
Okay, हाँ, one thing is sure that if we say that this patient malignancy is not in the liver, anywhere else.
Okay, sir.
Can it be possible?
Sir, but then there will be lot of weight loss because फिर दिन meds होंगे, उसके बाद ही there will be jaundice.
Weight loss ही तो है. इस पेशेंट का वेट कितना है? इस पेशेंट का तो he is completely emaciated.
Sir, but sir, लेकिन recently तो weight gain की history थी in history part.
अच्छा, वो that I know, but अदर ऐसा ही कोई सिनेरियो हो जैसे पेशेंट मेल है, प्रोस्टेट के लिए मैलिग्नेंसी है, इट कैन मेटास्टाइज टू bones, it can metastasise to peritoneal cavity, but in that case then the spleen is difficult to explain. Splenomegaly is difficult to explain in that case. You can explain the jaundice, you can explain the hepatomegaly, you can explain this thing ascites, you can even explain the pedal edema also, but not splenomegaly. क्योंकि स्प्लीन में मेटास्टाइज नहीं होता इतना, लिवर में मेटास्टाइज होते हैं, पेरिटोनियल डिपॉजिट्स बन जाते हैं, पेशेंट लीन एंड थिन एमेशिएटेड इज होता है, हाइपोएल्ब्यूमिनिया भी वैसे आप लिडिमा भी एक्सप्लेन कर सकते हो, ठीक है, बट not splenomegaly. So you have to see all these, and that's why we are keeping that possibility at a lower end, fourth या fourth fifth के. There is reason, इसीलिए तो हम उसको fourth या fifth कर रहे थे. First possibility तुमने यही रखी हुई है, cirrhosis. Then okay. Then it is dilated cardiomyopathy or abdominal tuberculosis, second or third, जो भी तुम्हें अच्छा लगे. Then be malignancy also, a rare possibility. But yes, you have to keep in differential, even if a rare possibility है तो वो भी तुम्हें रखनी ही है. That you also have to include. So try to always make 2 or 3 differentials. ठीक है. First differential should be, you should have points in favor, points against that in your, you should know what are your points in favor of that first differential, out of the points against that differential.
Okay, sir.
Okay. जो points against the differential हैं, that will make your next differential. Like in this case, जैसे तुमने cirrhosis बोला पर liver span increase बता दिया, तो कोई और differential हो सकता है ना? तो ऐसे तो उसी से differential बनेंगे. 3 और 4 differential होने चाहिए. कई cases होते हैं जहाँ differentials नहीं बनते हैं, तो वहाँ पे एक ही possibility होती है, एक ही रखो. The thing is, examiner को differential नहीं बताने पड़े. समझे? अब आप इसमें सिर्फ एक ही possibility रखोगे तो एग्जामिनर को ये लगेगा कि किसी को केस पता था और इसने बस आके सब फाइल वाइल पढ़ ली और प्रेजेंट कर दिया और कहीं सोचा ही नहीं. इफ यू थिंक, जितना ज्यादा सोचोगे उतना ज्यादा एग्जामिनर को लगेगा कि नॉलेज है, और that will generate discussion on this thing only. Okay, so always keep 3 or 4 possibilities. बाकी एग्जामिनेशन को जब करोगे तो वो है ही. ठीक है, मैं किसको बनाऊं? एनी अदर क्वेश्चन?
सर नो सर. सर आप मिताली को जस्ट अनम्यूट कर दो, मैं स्क्रीन उसकी खुद शेयर कर दूंगी.
ओके, 1 मिनट. मिताली, Mitali is now self-muted. Hello.
Hello.
Yes, sir.
Good morning, sir.
Morning, Mitali. Go ahead.
Sir, I'll be leading on with investigation and management. Next slide, please. So first we'll be doing routine blood investigation like complete blood count, and in our patient we'll see we'll be having anemia, megaloblastic anemia. So mainly because due to vitamin B12 deficiency in alcoholics, and also due to hypersplenism, and also because alcohol invades the bone marrow, it destroys the bone marrow, it basically suppresses the bone marrow. And so there will be thrombocytopenia because thrombopoietin won't be produced by the liver. In prothrombin, time would be prolonged, sir. Bleeding and clotting time would be prolonged. So in liver function test, we'll do serum bilirubin, in which there would be predominantly unconjugated hyperbilirubinemia. ALT and AST level would be deranged, and in which AST by ALT ratio would be more than 2. So because SGPT or AST, SGPT and ALT basically needs pyridoxine for synthesis, and ethanol inhibit the pyridoxine synthesis. So this is the reason why AST would be higher than ALT. And so serum gamma glutamate would be increased. Then ultrasound abdomen would be the sensitive investigation, which can detect as less as 100 ml of ascitic fluid. And I have discussed it on further slides. Then we'll go for endoscopy for
Okay,
upper GI tract.
Mitali,
Yes, sir. Yes, sir.
uh, you tell me what you expect in this case in ultrasound abdomen.
So, since it's a
What do you want to look?
ascites,
Huh?
sir, it's a case of ascites. So, sir, basically, in massive ascites, the small bowel loops would have a characteristic lollipop, polycystic lollipop or arcuate appearance, because on either side, because they will be arranged on either side of the vertically floating mesentery. And some if ascites is due to infected or inflammatory or anything other etiology, then we could see other changes like coarse internal echos would be seen in case if the blood is present, or fine internal echos if chylous ascites is chylous ascitic fluid is there, or multiple septa in case of tubercular peritonitis or
Okay,
pseudomyxo. Yes, sir.
okay, okay. My question is that this is a case of first differential is by Mehak is a case of cirrhosis with portal hypertension. So,
Yes,
what
sir.
are your expectation on ultrasonography in this case?
So,
इसमें क्या expect करोगे?
So, since it's a case of ascites, the fluid would collect in the Morrison pouch and around the liver, and uh, and
तो
if it is a
completely इस केस में तो fluid freely present है तो it's not
it's a
only
massive
Morrison
ascites.
pouch so it's a massive
So,
ascites तो fluid
yes,
तो आ ही जाएगा उसमें
so
ठीक है
we will
लेकिन
see lollipop appearance.
no ये तो बड़े lollipop appearance is not a small bowel it's does it add to your diagnosis फ्लूइड तो वैसे ही दिख
Uh,
जाएगा उसमें ascites में तो लॉलीपॉप अपीयरेंस देखने की क्या जरूरत है your expectation is not this you have to see what is going on in the liver so what do you
uh,
expect in liver what do you
so
expect in
ultrasound
liver
would also, yes, sir. So ultrasound would also show the splenomegaly and abnormal liver texture.
abnormal liver
Texture. So nodular cirrhosis is there. So basically, the
yes
liver would appear nodular.
yes so the liver will now the liver in this case since we are keeping diagnosis cirrhosis so we expect that the liver size should be reduced and the ecotexture should be enhanced. So
Yes,
it
sir.
is more enhancing ecotexture and with nodular appearance. That will
Yes,
give us
sir.
the diagnosis that the liver is enhanced, the ecotexture is enhanced, and the size is reduced, and the surface of the liver is nodular.
Yes,
And
sir.
along with ascites. What else you can see on ultrasonography in this case to make your
Uh,
diagnosis?
so we would see splenomegaly. Splenomegaly would be present.
Okay, splenomegaly, you can see the size of spleen. What else?
Yes, sir. Uh, so, so in this case, I think that's it. I don't know, sir.
There is one diagnosis. There are two things involved in cirrhosis with portal hypertension. So what else you
Yes,
can
sir.
see?
Uh,
Portal
so
vein.
So yes, so portal vein could portal hypertension. So portal vein would be dilated, but in
Yes. So the
to
diameter of the portal vein is
would be
enlarged.
yes, sir.
The enlarged ना in this case. So
Yes, sir.
ये केस है तुमने इसको अल्ट्रासाउंड के लिए भेजा उसमें ये सारी फाइंडिंग आ गई.
Yes, sir.
There is ascites, the liver size is shrunken, ecotexture is enhanced, and the nodular surface is there, and portal vein is also dilated, diameter maybe
Yes,
13, 14 millimeter. So
yes,
then
sir.
it becomes the diagnosis become clear.
Yes, sir.
That is a case of
Sort of.
cirrhosis with portal hypertension. तो इसमें
Yes, sir.
लॉलीपॉप और बाउल और देख के क्या करेंगे हम?
So I read that somewhere, so
वो तो
I
रेड
wrote
वो
it.
तो रेड है वो तो that's a radiological feature because of ascites bowels compress हो जाती हैं तो ये हो जाता है वो हो जाता है बावल से कोई वो नहीं इससे लेना देना what's more concerned in this three or four things is the spleen liver portal vein and ascites
Okay, sir. Yes, sir.
Okay, so that will
Yes,
give
sir.
you a diagnosis. You can say that this free fluid में अगर आपको internal echoes दिख जाएं, matting दिख जाएं, और mental thickening भी दिख रही है, so that it
Yes, sir.
adds, it will give you an alternative diagnosis also, or along with cirrhosis you give add-on diagnosis also. I would say the add-on diagnosis. अगर मैटिंग दिख रही है, क्लम्पिंग हो रही है, ओमेंटल इकोस दिख रहे हैं, ओमेंटल थिकनिंग दिख रही है, ठीक
Yes,
है,
sir.
और स्मॉल बॉल थिकनिंग दिख रही है, so this will go towards more towards tuberculosis then. Okay.
Yes, sir. Yes, sir.
But remember thing, the on ultrasound, when you are sending or doing an ultrasound of a patient like this, you have to focus on the liver echo texture, liver size, portal vein, spleen and ascites. इतना आपको मिल जाएगा तो you can easily make your diagnosis. Okay. चलो आगे चलो मिताली. Next. ठीक है. Next. Read it out for others. Mitali, read it out.
Hello. So, am I audible now?
And you are audible now. Read it out.
Okay, sorry, sir. Sorry, sir. Sir, a cytic fluid study in basically diagnostic parasynthesis, in which we take prior to the procedure, we ask the patient to empty the bladder so the bladder won't be injured, and we take 10 to 20 ml of a cytic fluid via the cytic tap using 22 gauge needle, and it is most commonly done in the left lower quadrant because it is the deep pocket and also it's the least vascular area. But the other sides of parasynthesis could be in the midline between pubic symphysis and the umbilicus, or the right iliac fossa lateral to the inferior epigastric artery. So the parasynthesis is done using Z technique. So Z technique is done because it reduces the leakage following the procedure, as puncture on the skin and peritoneum are not adjacent to each other. And so there are few contraindication of parasynthesis, like if the patient is having any local or severe abdominal infection, or if the patient is having severe coagulopathy. There are few complications following parasynthesis, that is infection of peritonitis, perforation of bladder, and the blockage of the needle. And if the rapid removal of a cytic fluid is done, patient can land into hypovolemia and shock.
Okay. Again.
So, through a cytic fluid, we can also do following tests. We do these tests like cell count. In our patients, it's normal. That is, neutrophilic count and WBC are less than 250 and less than 500 respectively. The gram stain and cultures are negative in our patient. Proteins are less than 2.5 gram per deciliter. That shows and amylase are less than 1000. Cytology is negative, and albumin and total protein is done for the calculation of serum ascitic albumin gradient. So, sir, the protein is less than 2.5 gram per deciliter, shows that it's a transudative ascitic fluid. And amylase being less than 1000 is pointing that patient is not having acute, and it's not acute pancreatitis. And cytology is basically done for ruling out the malignant causes. And further, we'll do SAG. Mehak? So this is basically what all we see in a cytic fluid. So through its ascitic fluid gross appearance, we can see if it is a clear or a straw colored fluid. It's also I don't know, sir, whether it's rightly written normal. I don't know, but it is seen in cirrhosis and also in some cases of TB. If it is the fluid is hemorrhagic, then it is seen in TB peritonitis, malignancy, trauma, acute pancreatitis. Again, sir, I'm not sure of acute pancreatitis because their black color is seen. Then following a traumatic tap, cloudy turbid is seen in bacterial peritonitis, and milky fluid can be due to chylus and pseudochylus. Then further, we have to differentiate between pseudochylus and chylus is like Then other tests which we can do is specific gravity. It's less than 1.018 in transudative and more than 1.018 in exudative. Protein level less than equal to 2.5 gram per deciliter is in transudate and more than 2.5 gram per deciliter in exudate. Then glucose, basically it is low in malignancy, TB and peritonitis because malignant cells or bacteria, they consume the glucose, and amylase of more than 1000 units per liter signifies that patient is, it's a case of acute pancreatitis. Then, sir, other things which we can do is microscopy and culture. If normally microscopy is less than 250 cells per millimeter cube, it's seen in cirrhosis. And if it is more than that, it signifies that infection is present. And same with WBC, its normal is 500 per unit liter. If it's more than, it signifies infection. Then we'll do gram staining and Zn staining for bacteria and culture also. Next.
Okay.
So, yes, sir. So, serum ascitic albumin gradient, it's a very useful procedure. And basically, if it is more than 1.1, it signifies that ascites is due to portal hypertension because if it is more than serum ascitic albumin gradient more than 1.1, it signifies that due to sinusoidal pressure being increased, since sinusoids are impermeable to albumin because sinusoid epithelium are deeply fenestrated, do not allow the leakage of albumin outer. So, it is mostly pointing out that in ascitic fluid we are having a lower albumin concentration. So it is most likely due to sinusoidal causes, which includes cirrhosis or veno-occlusive disease or post-sinusoidal causes like Budd-Chiari or constrictive pericarditis. And so if it is less than 1.1, it can be in two cases, like if the serum albumin is reduced or the cytic albumin is increased. Now, if serum albumin is reduced due to, it basically means that due to the reduced oncotic pressure, fluid is leaking out from the peritoneum into the peritoneum vessels into the peritoneum, which is seen in nephrotic syndrome. And if a cytic albumin is increased, which means that blood vessels permeability is increased, allowing the protein to leak out, which is mainly seen in when there's a peritoneum inflammation, which can seen in TB, peritoneal carcinomatosis due to mets from mesothelioma or adenoma, and TB or acute pancreatitis or yes, sir. And then, sir, further, if the serum ascitic albumin gradient, we are getting it more than equal to 1.1, that is high SAG gradient, high SAG, then we further do with ascitic total protein, which help us in differentiating whether the portal hypertension is due to cirrhosis or it is non-cirrhotic. So, sir, if it is less than 2.5 gram per deciliter, it is cirrhosis because in cirrhosis the walls are fibrous, so it is not allowing, it is allowing the leakage of water, but it won't allow the leakage of protein. So high sag and low protein signify that it is cirrhosis. While if it is more than 2.5 gram per deciliter, that is high sag, high ascitic protein, then so it is like non-cirrhotic cause like post-sinusoidal, like in Budd-Chiari, because it is allowing at least small leakage of protein along with water. So,
Okay.
then sir, the sir management, shall I continue, sir?
Continue.
Okay.
Okay, sir.
So,
Let's wait. So,
yes,
what
sir.
else investigation would you like to do apart from this SAG and ultrasound and all these things? Would you like to do the Doppler ultrasonography?
Yes, so as you said, we have to see the portal hypertension. So through Doppler USG, we can see the portal vein diameter and we can find out the portal hypertension.
So, see, the portal vein diameter and portal vein can be easily visualized with the normal ultrasound or 2D ultrasound also. The Doppler
Oh,
is done for something else. Doppler is one thing, the real time ब्लड फ्लो वो देखने के लिए करते हैं, तो वो अगर इसमें कराना चाहें तो क्यों कराते हैं?
so portal vein,
वेन तो
flow
हम
of
इसी में
blood in.
देखेंगे, फ्लो ब्लड कैसे क्या, व्हाट डू वांट टू सी? अगर मैं इसमें इसी केस में
So,
ऑर्डर कर दूं कि आई वुड लाइक टू डू ए Doppler SP axis, that means the Doppler splenoportal axis.
Yes, sir. Sir,
उसमें हमें
portal
क्या
vein
देखना
and
पड़ेगा?
hepatic artery, sir? I don't know, sir. I'm not sure.
We have to see the direction of the blood flow, whether it's centrifugal or centripetal.
Okay, sir.
Okay, so if it is
Okay, sir.
centripetal, that means the flow is still towards the liver, and it signifies that the prognosis is still good for this patient.
Okay, sir.
But once it becomes fugal, then it carries a very bad prognosis. Okay,
Okay, sir. Okay, sir.
so there is one entity which we do is for not for the diagnosis, for the prognostications. है ना? That is,
Okay, sir.
apart from that, any thrombosis or any other thing, obstructive disease like thrombosis, splenic vein thrombosis, portal vein thrombosis can be easily identified by the
Doppler, sir.
Doppler. Okay. Then
Yes,
the
sir.
second
Yes, sir.
investigation I would like to say that is upper GI endoscopy.
Yes, sir. To see whether varicose, upper esophageal varicose beads are present or not in due to portal
Yes,
hypertension.
yes, yes. If I say with this case, I don't have much resources. I would like to do only one investigation to make the diagnosis. Which one you would like to do?
Sir, endoscopy.
Endoscopy. Why?
Uh, Sorry, sir. You are asking like between endo and Doppler or in general, sir?
No, no, but I would like to do only one investigation in this case, and that will give me the diagnosis.
So, according to me, I think ultrasound abdomen and ALT and AST level should be done.
Okay, okay. So ultrasound abdomen will give you the diagnosis,
Yes,
and
sir.
usually, okay, the endoscopy is needed for the to see the varicose bleed. But when the
Yes, sir.
ultrasound abdomen is not available, you can go for the endoscopy also. If it shows varices, that means the case is of portal hypertension.
Yes, sir. Okay, sir.
Okay.
Yes, sir.
What else you can do in investigations?
So, other investigations, so I think so eco or I don't know, so other investigations,
Okay.
the CT scan
Echo,
could
other
be
if you
done.
think if a differential like in this, we were keeping this that thing. So the echo can be a possibility, and alpha fetoprotein.
Okay, so alpha fetoprotein. Yes, sir. Yes, sir.
The cirrhotic patients in the cirrhotic patients, the risk of hepatitis carcinoma is very high. So they are
Okay, sir.
needed to be screened every 6 months.
Okay, sir. Yes, sir. ठीक.
So alpha fetoprotein, you have to do the alpha fetoprotein also.
Okay, sir.
ठीक है? अच्छा
Yes,
आगे
sir.
बोलो मैनेजमेंट.
Next. Firstly, we'll go for general measures like we'll do hospitalization of the patient. In our case, it's massive ascites, so we'll hospitalize the patient. We'll check the serum electrolytes and urinary electrolytes every twice a week, and then we have to weigh the patient daily, like measure the abdominal girth and have to monitor the strict intake and output monitored. Then, sir, I'm not sure about this point. I've read that bed rest induce diuresis in some people because in horizontal position the renal blood flow increases. But I'm not sure whether I should. It's actually possible or not.
To bed rest, we advise bed rest to the patient just for the it doesn't induce the diuresis, but it reduces the pedal edema and all those things.
Okay.
Okay,
Okay.
so bed rest will
Okay.
not induce diuresis.
Okay, sir. Then we'll ask the patient for dietary sodium restriction. And sir, in Harrison, I think I read ki we restrict the sodium intake to 100 millimole per 24 hours. But
I
somewhere
don't
else, I
remember it's in millimole, but it's less than 2 gram.
yes, sir, 2 grams per day. Yes, sir.
2 grams per day. That's the other. Millimole is because we will not be able to explain the patients daily in millimole. Okay,
Okay.
and for millimole per hour, ये तो कहीं this doesn't look nice, na?
20, it should be 24 hours, I guess.
40 millimole per hour बेचारा patient कैसे निकालेगा? Okay,
Yes,
so
I'll
you need to explain the patient ना, millimole वो
yes.
कैसे पता करेगा?
Okay,
So you
sir.
have to explain it that it should be less than 2 gram
2
per
gram
day.
per day. Yes, sir. Yes, sir.
हाँ,
Then, sir, also we advise the patient that if he's having consuming any drugs which are having sodium in it, that should be avoided. Like many effervescent tablets and antibiotic like penicillin, cephalosporin, NSAIDs contain sodium in it, and also sodium valproate. Then, sir, after initial treatment, initially we advise the patient for salt restriction. In that, we always have to make sure to ask we always have to keep checking the urine sodium level. If this urine sodium is to potassium level is more than 1, it means the patient requires further salt restriction. So I think slide थोड़ी ऐसे mix हो गया, but I'll speak it out. If the urine sodium is to potassium level is less than 1, it means the patient is abiding, patient is following salt restriction. So then we have to start with drug therapy, in which we add 100 milligram of spirolactone, which is the aldosterone antagonist, and then we have to add 40 milligram of furosemide. So the ratio is of 40 is
where
to
have you
100.
read all this urinary sodium level and all that? कहाँ से देखा?
So I read it from the notes, like,
Okay, it's not required. We
okay,
can't
sir.
do urinary sodium level daily for so long. Okay,
Okay, sir.
so we need to give the patient diuretics. See,
Okay, sir.
very simple thing. When you need to give the patient diuretics, the
Yes, sir.
preferred diuretic is spironolactone.
Yes, sir.
The reason being, first, it's a slow diuresis. Second, it will not cause hypokalemia.
Yes, sir.
Okay,
Yes,
we
sir.
need to monitor hypokalemia first, because if patient goes into hypokalemia, then patient will go into hepatic encephalopathy.
Yes, sir. Hepatic encephalopathy. Yes, sir.
Because hypokalemia will induce hepatic encephalopathy. So
Yes, sir.
spironolactone is slow diuresis and it will not cause hypokalemia. So that's why the spironolactone is the preferred uh, diuretic. But
Yes, sir.
if spironolactone alone is not sufficient, then we have to add furosemide,
Furosemide. Yes, sir.
which is a potent one, very potent diuretic, but it will cause
So it
hypokalemia.
can, yes, sir. Fluid and
Uh,
electrolyte imbalance.
it will cause hypokalemia. So to balance that out, you can give spironolactone and furosemide both in a ratio of 40 is to 100.
40 is to 100. Yes, sir.
So if you give in that ratio, then it will be balanced out, and the diuretics will not cause either hyponatremia or hypokalemia or hyponatremia, whatever.
Yes,
It's
sir.
a very practical thing. Doing daily urinary sodium level is very cumbersome. मॉर्निंग में आप
Oh,
यूरिन सोडियम लेवल भेजोगे, शाम को उसकी रिपोर्ट आएगी, देन यू विल ऑल्टर योर दिस थिंग ट्रीटमेंट, देन मॉर्निंग में फिर इट्स वेरी कुम्बरसम ना. For
okay,
once
sir.
it can be done, but not for daily thing. So remember thing, the spironolactone, furosemide, the preferred one is spironolactone. If it does, if it is sufficient for the patient, go with it spironolactone. If it is not sufficient, if you need to add another diuretic, then add furosemide. But
Furosemide.
you need to balance that out, and the balancing ratio is for 40 is to 100.
Yes, sir.
That much you need to remember. Okay.
Yes, yes, sir.
So no role of
Uh,
midodrine in this.
okay, sir.
ये जहाँ से भी पड़ा है इसमें no role of midodrine. Midodrine has no role.
Okay, sir. So it was written कि if this is patient is unresponsive to this therapy, then we have to add L5 midodrine, and if it also unresponsive to with that, then we have to do therapeutic parasynthesis
No,
every
no, no,
2 weeks.
no, no role of midodrine.
Okay.
Midodrine is only used in one condition in this case, that is hepatorenal syndrome.
Okay,
That too is if the hepatorenal syndrome is type 2. There are two
okay.
types of hepatorenal syndrome, type 1 and type 2. The
Type 2.
type 2 is more of a chronic hepatorenal syndrome, like slowly developing and at a low level, but it is continuous. In
Yes,
that
sir.
case, midodrine is required. Otherwise, midodrine is not required because midodrine is not diuretic. It's a alpha 2
Okay, yes, sir.
antagonist. है ना?
Agonist. Yes, sir.
So it is not diuretic. So midodrine is not needed. So
Okay, sir.
spironolactone furosemide you need to give. Then अगर नहीं होता है तो आप therapeutic parasynthesis कर सकते हो, ठीक है? और then there are other modalities also. आगे बताओ क्या लिखा है?
Then, yes, so then there's a term called refractory ascites, which is basically if the patient is not responding to maximum dose of spironolactone and furosemide, that is 400 milligram per day and 160 milligram per day, and it recurs rapidly after therapeutic parasynthesis, that is refractory ascites. So in the refractory ascites, the management is IV albumin in a dose of 6 to 8 grams per liter of ascitic fluid is removed. Uh, with 6 to 8 gram of per liter of IV albumin with large volume parasynthesis, in which we remove slowly. There's only 3 to 5 liter of fluid is removed slowly, because if rapid removal of fluid is done, the patient can lead to if the rapid removal is done from the peritoneal cavity, due to sudden removal, sudden decline in pressure would be there in abdominal peritoneal cavity, which would further lead to leakage of fluid from into the peritoneum from the vessels due to suction force. Therefore, to prevent this, we add IV albumin in a dose of 6 to 8 gram per liter of ascitic fluid removed. And so it was written if IV albumin patient is not responding to IV, then we can even add dextran with large volume parasynthesis. I don't know whether it is right or wrong.
When IV albumin is not available.
No, sir, when a patient is developing some complication, it was written something like if the patient isn't responding to IV albumin or the patient is developing complication due to IV albumin, then we have to switch to dextran.
If patient is developing complications to IV albumin, then yes, we can use dextran. But if IV albumin is available and there are no complications, then the IV albumin is the drug of choice for this purpose.
Okay, sir.
Okay,
Yes,
dextran is
sir.
not the
Yes, sir.
drug of choice. Dextran is only
Yes, sir.
used when IV albumin, say patient is having some reactions or something like that, or it is not available.
Okay, sir.
Okay, so
Okay,
it's a
sir.
second alternative only. First
Okay.
alternative is only IV albumin. In this
Yes,
slide,
sir.
no role of midodrine. Again, no role of midodrine for the treatment of ascites. Midodrine is being used for type 2 HRS,
Hepatorenal syndrome.
hepatorenal syndrome. Maybe
Yes.
इसमें इसलिए लिखा होगा कि अगर किसी को renal dysfunction है तो then we can give midodrine.
Okay. Yes,
Okay.
sir. Yes, sir.
So then the third modality is TIPS.
Yes,
Which
sir.
have
Transjugular.
intrahepatic. There are various types of procedures for the tips, side by side. So don't go into that much of detail. Just remember, tips is one modality to reduce the
Okay, sir.
ascites only.
Yes,
See,
sir. Okay.
so
Yes,
to
sir.
reduce the ascites, to reduce the portal pressure. That's it. It will reduce the
Yes, sir.
portal pressure only, and
Okay, sir.
by reducing portal pressure, it will reduce the formation of ascites. Okay, but
Okay,
there is one dreaded complication of tips is that if you do the tips, then patient will go
patient.
into hepatic
Hepatic.
going to recurrent hepatic
Hepatic.
encephalopathy.
Yes,
ठीक है? And then
yes,
the third is the liver transplantation.
yes.
Okay, आगे
Uh, so this is, sir, could
this
you
is all
see
you
the
have.
slide?
इसमें तो सिर्फ एरो एरो आ रहे हैं.
Yes, sir. So it just dotted. I don't know. But, sir, basically, this was the algorithm that if the patient is having grade 1 or grade 2 or grade 3 ascites, then what all we do, I'll just speak it out. So if the patient,
nothing is grading. Ascites is not graded. मिताली
okay,
तुमने
sir.
कहीं भी पढ़ा है ना, माइल्ड मॉडरेट सीवियर, ऐसा ascites का कोई ग्रेडिंग नहीं है. It's just
Okay, sir.
the we have limited resource, limited options available for ascites. Just I said that first you do the all those things: bed rest, diet restriction, and dietary sodium
Sodium
restriction,
restriction.
and high protein diet. If it does patient
Yes,
does well
sir.
with this, it's okay. No need of giving diuretics also. But if you want to get, if the patient is not this thing sufficient for this, then add spironolactone. Then if not controlling with this, then add furosemide. And then not
Okay, sir.
responding, then do the parasynthesis. If it is still
Okay,
not
sir.
responsive, then other things like tips or liver transplant or something like that. It's not
Okay,
mild,
sir.
moderate, severe question. It depends on the responsiveness of the patient. Okay.
Yes, sir. Okay, sir. Okay, sir.
अगर
Uh,
ऐसा नहीं है कि सीवियर होगा तो तुम सीधा ही टिप्स कर दोगे. सीवियर भी है तो you have to start with your
uh,
initial
Parasin, it's diuretics.
diuretics, and you have to wait for 2 or 3 or 5 days. Okay.
Okay, sir. Okay, sir.
Okay.
Uh,
Any
thank
questions you
you.
have?
So there was a last algorithm which I wrote, Mehak. Uh, Sir, basically, it was written in Harrison only that if the patient is coming hospitalizing within 12 hours following parasynthesis, then there is good chance of saving the patient from the complication that is spontaneous bacterial peritonitis. So, sir, for that I just pasted an algorithm that shows that if the like following a diagnostic parasite, if the cell count is less than 250 or more than 250, then if the culture is showing positive for this one, so if the culture is, I don't know, so I'll speak it out, should I?
Okay. What is I will tell you. Just tell me the approach to ascites following a diagnostic parasynthesis. Diagnostic
Yes, sir.
parasynthesis cell culture. See this you are telling about SBP,
Yes, sir.
spontaneous bacterial
Bacteria peritonitis.
peritonitis.
Yes.
So
Yes, sir.
okay. The thing is it's not about the parasynthesis, diagnostic parasynthesis. So the SBP can develop even without uh, parasynthesis.
Yes, sir.
If we don't,
Yes, sir.
if we ऐसा नहीं है कि हम needle डालेंगे तो ही इन्फेक्शन जाएगा. गट बैक्टीरिया से भी इन्फेक्शन पेरिटोनियल कैविटी में इजीली ट्रांसफर हो जाता है, एंड देन दैट टर्म इज एसपीपी.
Yes, sir.
ठीक है. तो if you do the parasynthesis, if the cell count come out to be less than 250, polymorph. Remember that polymorph should be, the absolute polymorph should be less than 250. ठीक है.
Okay,
Then
sir.
it is said that patient is not having patient do not have SBP. If it is more than 250, then it is said that patient is having SBP, that is
Yes, sir.
spontaneous bacterial peritonitis. ठीक है.
Yes, sir. Yes, sir.
And then we need to treat it with the antibiotics.
Yes, sir.
If patient is developing recurrent SBPs, more than three, and patient has already developed more than three episodes of SBP, then it becomes that patient is having a tendency to develop SBP. So to
Yes,
prevent
sir.
then recurrence, then we need to give
Norfloxacin.
that we
Prophylactic
need to give
norfloxacin.
prophylactic norfloxacin daily or ciprofloxacin once weekly.
Yes, sir.
Okay, this is what
Yes,
this
sir.
this slide means.
Yes, sir.
बाकी तो इसमें जो कल्चर में आएगा वो आएगा जो उसके अकॉर्डिंग है, but the basic funda is that polymorphs should be less than 250, no need of antibiotic. Polymorphs more
Yes,
than 250, patient is having SBP, we need to give him the antibiotics.
yes,
Okay. We
yes,
to
sir.
start the antibiotics and send the culture, send the acidic fluid for the culture, or then after culture, whatever it comes on the culture based antibiotics we need to give.
Yes, sir.
Okay.
Okay, sir. Yes, sir.
Any other thing?
Uh, no, sir. That's it.
Oh, okay. Let me see if I can. I am sharing now my few slides. Most of we have discussed, but I have a lecture made for this now. Share. I don't know what is happening. Unless you.
Sir, actually, I'm the presenter, so you have to remove
Oh,
me.
no. Okay, okay. I have to remove you. But then,
Yes.
how will you know? How will I know whether my slides are visible or not?
Sir, first you have to remove me and you have to become the presenter. And then,
Okay. Really, I want to tell you all you guys what is portal hypertension. Portal hypertension is nothing but the hepatic venous pressure gradient is more than 5 millimeter of mercury. So the clinically significant portal hypertension is when it exceeds more than 10 millimeter of mercury, and when the hepatic HVPG, that hepatic venous pressure gradient, is more than 12 millimeter of mercury, then the chances of variceal bleeding is more. So remember this thing, that portal hypertension is nothing but HVPG, more than 5 millimeter of mercury. How do we take portal pressure? We take portal pressure by an invasive procedure. We introduce catheter through the either by the internal jugular vein or by the femoral vein, and measure the pressure in the measure two pressure, that is wedge hepatic pressure and free hepatic venous pressure. And the difference between the wedge hepatic pressure and free hepatic venous pressure is the hepatic venous pressure gradient. This is the portal system venous. You can see that how does a portal vein make the splenic vein with superior mesenteric vein. So when it combines, it becomes a portal vein in the behind the head of the pancreas at the level of the L2 vertebra. This is important. The classification of the causes of portal hypertension. The three we have classified into three. That's prehepatic. Intrahepatic is further classified as pre-sinusoidal, sinusoidal, and post-sinusoidal. And post-hepatic is In prehepatic causes, there can be portal vein thrombosis, splenic vein thrombosis, or per se massive splenomegaly can cause portal hypertension. Prehepatic cause of portal hypertension, the liver is absolutely normal. Outside liver, the cause lies, and so it carries a good prognosis. In hepatic causes, pre-sinusoidal is schistosomiasis, congenital hepatic fibrosis, primary biliary cirrhosis, and chronic active hepatitis. Sinusoidal is the cirrhosis of liver and alcoholic hepatitis. And in post-sinusoidal, it is hepatic sinusoidal obstruction or the veno-occlusive syndromes. Post-hepatic is like Budd-Chiari syndrome, inferior vena cava obstruction, or cardiac causes like constrictive pericarditis, restrictive cardiomyopathy, severe congestive heart failure. This is diagram showing the causes and the site of the blockade of the portal hypertension. You can see in extrahepatic congenital causes, the cause can be congenital, can be umbilical sepsis, trauma, or any hypercoagulation state or malignant occlusion. Similarly, in intrahepatic, pre-sinusoidal schistosomiasis, congenital hepatic fibrosis, and primary biliary cirrhosis. Sinusoidal is predominantly cirrhosis and alcoholic hepatitis. This is the pathophysiology. Now I'm audible. Hello everyone. I am audible. Okay. Okay. The fundamental hemodynamic abnormality is the increase in the resistance to the portal blood flow. The portal blood bypasses the liver through the bypasses through the liver and enter the systemic circulation without being detoxified. So that is the pathophysiology. And at the same time, the portal flow increases in the splanchnic bed due to splanchnic vasodilatation and increase cardiac output. So basically, the pathophysiology is nothing but the increased resistance to the portal blood flow, which leads to the development of the collateral vessels, and then portal blood bypasses the liver and enters the systemic circulation. So this is a diagram showing the pathophysiology that there is increased resistance to the portal blood flow in cirrhosis because of liver cell injury. There is a stellate cell activation, and then stellate cell will transform into myofibroblast, and then there is expression of these prostaglandins, endothelins, and nitric oxide, which causes splanchnic vasodilatation and contraction of these activated cells. So there is abnormal blood flow pattern causing increased resistance, which further leads to fibrogenesis and increased resistance to the portal hypertension. This is not important. So there is resistance to the portal blood flow. This in cirrhosis. The resistance can be because of two things. One is mechanical. The mechanical one is because of the fibrosis, nodules, or disc collagens, and then there can be dynamic because of the myofibroblast, endothelial cells producing endothelin and nitric oxide, and because of the portal collaterals. So this all two will lead to the rise in the portal pressure, and development of the portal systemic collaterals. This one is not important. So this one is important for you. What is collateral circulation? Since there is a increased resistance and blockage to the portal blood flow, so there are formation of collaterals. So it is bypass the blood from the portal vein will bypass liver and directly enters into the systemic circulation through these collateral circulations. Where are these located? So one is this. There are four sites, group of sites. The first one is the at the cardia of the stomach and at the rectum, which are the varices and the hemorrhoids. The second group is the at the umbilicus in the falciparum ligament. The third group is over the umbilicus, which causes the term caput medusae. The third one is the collaterals in the abdominal organs, which are in connectivity to the retroperitoneal tissues. And the fourth one is the portal vein. Blood is carried to the left renal vein through the blood entering directly into the splenic vein. So you will be asked in your exam where you all will be finding the collateral circulations, the sites on the abdomen. So what is the mechanism of ascites in the case of portal hypertension? What the factors involved are that there is increased portal pressure with vasodilation of the splenic arterial system. There is sodium retention due to activation of the RAS system because of hyperaldosteronism, and which causes fluid accumulation and expansion of the extracellular fluid. And because of this splenic vasodilation also leads to the sodium retention. The third one is hypoalbuminemia. Because of hypoalbuminemia and reduced oncotic pressure, ascites formation is there. Sodium retention with leads to this RAS activation. There is flanking vasodilatation, which further leads to the sodium retention, and there is hypoalbuminemia. So these three are the causes for development of the ascites in portal hypertension. Cirrhosis is the commonest cause of portal hypertension. What clinical features we already discussed in the case presentation? It can be hematomesis, blood in vomitus, melena because of the varicose bleed, ascites, pedilledema, caput medusae, signs of chronic liver failure, anorectal varices, encephalopathy, flapping tremor, and splenomegaly. So diagnosis of portal hypertension, the specific modality used for the diagnosis in imaging, it can be ultrasonography, which gives you much information, which we already discussed in the investigation and management by the Mitali. That ultrasonography, we need to see the liver size, echo texture, portal vein diameter, ascites formation, and spleen. Doppler ultrasonography will give us the flow of the blood in the portal vein, whether it's the centripetal, that means towards the liver, or centrifugal, that means away from the liver. If it is towards the liver, it carries a good prognosis. If it's away from the liver, it carries a very bad prognosis. Then other modalities as CT contrast, arteriophotography can be used, or MR angiography can be used, just to see the localize the thrombus in some cases. Then upper GI endoscopy will give you the whether the patient is having esophageal varices or not. If esophageal varices are there, that confirms that patient is having portal hypertension. What are the complications of portal hypertension? Variceal bleeding is one, congestive gastropathy, second, then hypersplenism, because portal hypertension causes splenomegaly, and splenomegaly sequesters the RBCs and may cause pancytopenia. So that is hypersplenism. Or it can cause anemia. Then ascites, hepatorenal syndrome, hepatopulmonary syndrome, and hepatic encephalopathy. So these are the complications of portal hypertension. So this is how the endoscopy is the best modality to see the varices. There are three three grades of varices: grade 1, grade 2, grade 3. So how will you manage a acute variceal bleed? First of all, we need to do the diagnostic endoscopy. We should monitor hemodynamically. Hemodynamically, patient should be monitored. His blood pressure, pulse rate, respiratory rate should be monitored. Fresh frozen plasma, vitamin K, and platelet transfusion whenever required should be administered. Hepatic encephalopathy is prevented by giving lactulose, as the blood from the varices will fall down in the small intestine. It will cause bacterial fermentation and patient will go into further hepatic encephalopathy. So we have to prevent that hepatic encephalopathy by giving lactulose. Then we can use some drugs, vasoactive drugs, which we'll talk later on. Then there is one entity called as endoscopic sclerotherapy or variceal banding. We do the endoscopy, we find that there is a varices. If the varices are small or either grade 1 or grade 2, then we do the sclerotherapy. We just inject one injection of sclerol or alcohol or some sclerosant agent into that, and it will fibrose. Or if the varices are of grade 3, then we band them through the endoscope. If endoscopy is not available and patient is bleeding, then we may try Sengstaken Blackmore tube. And when patient is having recurrent variceal bleeding and needing recurrent endoscopy, recurrent insertion of Sengstaken Blackmore tube, then we can do the TIPS procedure also to reduce the portal pressure. So we need to do the endoscopy first, diagnose the disease. If the endoscopy shows grade 1 or grade 2 varices, we either put the sclerotherapy or band. If that is not possible, then we need to do the Sengstaken Blackmore tube insertion. Drugs which can be used for the acute variceal bleeds are vasopressin and terlipressin, somatostatin, octreotide. So commonly, octreotide is the commonly used drug. The combination therapy from with vasoactive drugs and endoscopic band ligation or sclerotherapy is the therapeutic gold standard treatment for an acute variceal bleed. TIPS is a procedure where an expandable metal stent is inserted between the portal vein and hepatic vein, producing an intrahepatic photosystemic stent. It will reduce the portal pressure and reduce the variceal size also. So the bleed can be reduced. This is how a Sengstaken Blackmore tube works. It has 4 outlets. One is for gastric aspiration holes through which we can aspirate whatever the gastric contents are there. The second is for esophageal aspiration. Third one is for esophageal balloon, and fourth one is for gastric balloon. We first insert into the stomach, just as we insert it through the Ryle's tube. We need to inflate the gastric balloon and esophageal balloon so that a tamponade can be created in and around the esophagus, esophageal varices. We keep it there for 48 hours and in timely deflation of the esophageal balloon for 10 to 15 minutes in every 6 hours, so that there should not be any pressure necrosis. And then we remove it after 48 hours. What is secondary prevention of variceal bleed? Secondary prevention, the ones just to reduce the incidence of bleeding. We may use beta blockers, which is used as secondary measure to prevent the recurrent variceal bleed. The three beta blockers which we can use for reducing the varicose bleed are propranolol, nadolol, and carvedilol. Doses used are those doses which reduce the heart rate by 25% of the patient. This we have already been explained by Mitali that SAG portal more than 1.1 is portal hypertension. If acidic protein is less than 2.5, then it is because is cirrhosis, Budd-Chiari, or massive metastasis. If the SAG is more than 1.1, but acidic fluid protein is also more than 2.5, then the cause may be congestive heart failure, constrictive pericarditis, IVC obstruction, or post-sinusoidal portal hypertension. If the SAG is less than 1.1, then it is non-portal hypertension causes like nephrotic syndrome, peritoneal carcinomatosis, and all that. Management of the ascites, we have already discussed bed rest, high protein, sodium restriction to less than 2 gram, and diuretics, both spironolactone and furosemide. For refractory ascites, the therapeutic options available are serial parasynthesis, peritoneal venous shunts, tips, or liver transplantation. That's it. Okay. So with this, we are ending this session. I must thank you, Mitali, and all the presenters. They presented very well.